There seems to be some mismatch in the photo and the CV.
Okay.
Anyways, they will pardon us.
In the presentation?
No. No, you introduce the speaker, Praveen Bhatti.
Okay. So now let us start our webinar on the non-operating room anesthesia. Our first speaker is Dr. Praveen Bhatti, who is working in group practice in freelancing since past 10 years. His special interest is in regional anesthesia, geriatric anesthesia, and labor analgesia. And he is going to enlighten us for anesthesia on bronchoscopy. Over to you, Praveen.
Yeah, thank you, Renu.
I'll share your slide.
Yeah. Am I audible? Hello?
Yes,
you are audible.
Before you start, Praveen, I'll just tell the participant not to write their MMC numbers in the chat box. We already have your MMC numbers. And please mute yourself when the speaker is talking.
and we already have a full house, sir.
Dr. Praveen, you can start.
Yes, madam. Just start.
Praveen, you can start.
I cannot see. It's not there. Renu?
You cannot see the presentation?
Yeah. The presentation is
Please
not coming on the screen.
stop screen sharing.
I am sharing. I will stop.
Yes.
Yeah,
Reshare kara. Yes, it.
Yeah, thank you. So,
It's visible now.
good evening, all my friends, my colleagues, my seniors. Thank you again. Good evening, all. Thank you, BSA. Thank you, Rao sir, and all the scientific committee to give me this lecture today for this webinar. So today we are all have included all the lectures on NORA, that is non-operating room anesthesia. Topic given to me is anesthesia for bronchoscopy. I'll just start my presentation.
Praveen, just say next slide when you want the slide to be seen.
Yeah. Okay, so by definition, bronchoscopy is an endoscopic technique to visualize the inside of the airways for diagnostic or therapeutic purposes. So what are the procedure basically needs special technical precision because both the anesthetist and the operating person, maybe the chest physician or the intensivist, they're all working on the same space. That is the airway. Next. Acha, what are the challenges for us working in endoscopy suite? First and foremost is the environment. The overall environment is not friendly because it is not done in the operation theater. It is done either in the endoscopy suite or in the ICU. Second is the staff is not familiar to us. So whenever there is crisis, we are not when they are not very helpful to us because we don't have very fine tuning as we have with the staff in the OT. Also, for all these procedures, we are usually called last moment. So last moment we are called, kuch to crisis ho gaya, please come see the. So whenever we go there, there is no IV, there is no airway equipments. So there is overall not a good scenario. One more is basically all the corporates, every institutes, everywhere, all the juniors are usually sent for all this NORA procedures, which is also not a good sign because maximum mishaps happens in endoscopy suits or whatever NORA procedures. Next. So bronchoscopy can be rigid or flexible. Rigid is basically done in the operation theaters. It is for diagnosis and treatment of the airway obstruction. And flexible is done usually by the chest physicians or the ICU intensivists for diagnostic and therapeutic interventions of the airway. So we will be discussing today about flexible bronchoscopy. It is basically covered in NORA, not the rigid bronchoscopy. Next. So what are the advantages of flexible bronchoscopy? The advantages are, one is it can be done bedside. Usually GA is not needed. It is done in conscious sedation. Patients are spontaneously breathing, and it is done in supine position. Usually is a day care procedure. Next. Okay, so what are the indications of flexible bronchoscopy? There are therapeutic as well as diagnostic. Therapeutic are aspiration of some retained secretions usually found in atelectasis lung in the patients who are in the ICU. One is bronchopulmonary lavage, which is usually done by the chest physician in the ICU or in the minor OT for the either open coughs or some neoplastic etiologies. Placement of endotracheal tube in difficult airway usually done by anesthetist or chest physician. Laser resection of tumor, airway stent, and any foreign body in the bronchus. That is done. These are the therapeutic indications. Next. We have diagnostic indications as well. So diagnostic are to diagnose the etiology of pneumonia patients, where the less invasive investigation does not conclude anything. Second is patients who have persistent unexplained cough. Third is patients of rejection in lung transplant recipients. Evaluation of airways in burns patients. Evaluation of bronchial disruption in chest trauma patients. Severe hemoptysis. Lung cancer staging is also done by this. And patients who have positive sputum cytology, but their chest X-ray is normal. Sometimes suspected tracheoesophageal fistulas and unexplained hoarseness or vocal cord paralysis patients are also diagnosed for some other reason. Next, please. What are the contraindications of flexible bronchoscopy? One is absolute and relative. Absolute is if the operator is inexperienced. There are facilities which are inadequate. Consent is not taken, and inability to maintain adequate oxygenation pre-op and intra-op throughout the procedure. Relative contraindications are profound refractive hypoxemia, uncorrectable severe bleeding diathesis, and malignant cardiac arrhythmias. Next. So how do we plan when a patient is posted for bronchoscopy? Usually all the patients are either ASA3 or ASA4, maximum patients. So we always do a proper thorough pre-op evaluation, either pre-op or 1 day prior to the surgery. Whatever routine labs are needed according to the patient's pathology, we do like a routine CBC, RFT, LFT whenever required, ECG chest X-ray always done, coagulation profile if required done, and Triple H status. We do PFT and arterial blood gas only where the patients are very critical to just see their respiratory and metabolic status. We just confirm their NBM status and proper consent is taken before the procedure. Procedure is explained to relatives and the patient if needed. Proper pre-op nebulization, bronchodilator nebulization is done to the patients, either saline or steroid nebulization. Sometimes IV steroids pre-op is given to patients where it is indicated. A nasal prongs is always advisable to put during the procedure. And as many patients, they are having a lot of infectious cases like open coughs or other cases. So proper mask, we should protect ourselves from all these infections during the procedure. And a reassurance is very important for bronchoscopy, because maximum time we are not giving general anesthesia to these patients. So good reassurance, explaining them the procedure, what are we planning to do, talking to the chest physicians or intensivists before the procedure, what are they planning to do, what are their, how much time duration are we expecting for the procedure. Accordingly, we plan our anesthesia. And anti-silog like injection glycopyrrolate is always given before the procedure. How do we monitor them intraoperatively? A minimum basic monitor of heart rate, ECG, SpO2, and NIVP. These basic monitors are always done. ETCO2 compulsory if we are doing the procedure in general anesthesia. Temperature monitoring is only for long procedures. Sometimes there are very critical patients of ICU, hemodynamically unstable. So we do have invasive lines like arterial or central line from them. Arterial blood ABG is for patients who have severe significant hypoxemia or hypercarbia. So what are the types of anesthesia we can give them? So broadly, if I classify, either it could be topical or regional or just inhalational of local anesthesia and some sedation. To start with topical anesthesia, if given along with sedation, the patients are usually comfortable during the procedure. And topical anesthesia, for nasal anesthesia, we give Otrivin drops or just a lignocaine spray to anesthetize the oral mucosa. 10% spray is good enough. Many times the chest physician just give nebulization of 4% lignocaine, and that actually suffices for short procedures. Next is regional block. Regional block, is it really needed? Are our friends, are our chest physicians really giving anytime regional block? I am yet to see. But we are routinely practicing regional block when we are planning fiber optic for our patients, where we are anticipating difficult intubations or commando, like patients of commando surgery or difficult airway. For regional blocks, the basic nerves are glossopharyngeal nerve, superior laryngeal nerve, and recurrent laryngeal nerve are blocks. We all, as an anesthetist, know how to block these nerves. For glossopharyngeal, just some local anesthesia below the base of tonsillar fossa. Superior laryngeal nerve basically anesthetize above the vocal cord, larynx above the vocal cords. It removes the cough reflex. So LA is just infiltrated above the thyroid cartilage, and for recurrent laryngeal nerve, it is just a transtracheal installation of local. But I do not see any chest physicians doing this regional block. Maybe one is they are very quick, hardly 10 minutes job. This regional block, actually, this needle poking is also not very the patients are also not very comfortable with all this. Next. Third is MAC. So monitored anesthesia care. I think maximum time we are called for this MAC. But whenever we go for MAC, we are always told thoda sa de do, thoda ye de do, because the patients are not comfortable. So MAC, we give sedation. MAC is monitored anesthesia care. So we always give some sedation. An ideal sedative should be easy to use, rapid onset, very short duration, and rapid recovery. Only special consideration for elderly patients we are doing, because they are prone for hypoxemia very easily. Okay, to start with the drugs of anesthesia drugs, the most common drug is benzodiazepines. In that, we do midazolam is the most common drug of choice, because it has a very fast, short elimination half-life and a faster onset of action. The dose is 0.01 to 0.1. Other drugs, other benzodiazepines are also sometimes used, like diazepam and all. Next. Opioids, they are very frequently used, and the most common opioid to be used is fentanyl, since it is a very short acting and has a rapid onset of action. The only thing need to be seen with drugs like fentanyl is if the dose is more, it can actually give severe bradys, and for geriatric patients, hypotension can also be seen. The dose is 1 to 2 mics per kg. Other opioids like Fortwin and nalbuphine are also routinely used in the endoscopy suite. The anesthesia drug propofol, which is short acting, we are routinely using for bronchoscopy for moderate sedation. It has a rapid onset of action and rapid recovery. Higher doses actually can give sometimes respiratory depression. It is usually given intermittent boluses whenever needed. The basic sedation dose is 0.5 to 1 mg per kg. Ketamine is also given in bronchoscopy for usually for children, sometimes also used in adults. The major advantage is it is a bronchodilator and it also has an analgesic action. The disadvantage is it gives a lot of secretion, salivation, and also increases your heart rate, blood pressure, since it is a sympathomimetic agent. Routine dose of 0.5 mg to 1 mg per kg is given to these patients. Next is dexmedetomidine. So this is a wonder drug. We all are using this everywhere, be it general anesthesia, sedation. Wherever we go, we are using this drug. It's a wonderful drug, selective alpha-2 agonist. It also has sedative and analgesic properties. The major advantages are it has a very less incidence of desaturation and respiratory depression. And post-procedure, the patients are actually well oriented and easily arousing. Very high doses, or if the dose is given very fast, severe bradycardia is seen. A dose of 1 mics per kg bolus over a period of 1 minute is usually given. There are newer drugs like phosphopropofol and remifentanil. Phosphopropofol is not available in India. The advantages of this is there is no pain on injection and the risk of bacterial contamination is not there like propofol. Remifentanil is recently launched in India. It is usually given along with propofol as a TCI pump. Next. Okay, bronchoscopy in ICU. We are many times called in ICU because the patients are really unstable to shift to the operation theater. So we are giving anesthesia in the ICU. It is very challenging. These patients are really unstable. They are on higher inotrope supports. They are hypoxemic. So for these patients, usually just you stop the RT feeds prior to the procedure few hours. Bronchoscopy is usually done through the endotracheal tube or the tracheostomy tube. Sedation and muscle relaxation is continued. Routine monitoring, pulse ox, saturation, your heart rate, BP and EPSO is done. Intermittent suctioning whenever required is done. The only problem with in all these patients when they do bronchoscopy through the endotracheal tube is these patients desaturate very fast. So they desaturate, we again connect our ventilator or a move, we bring up the saturation. Again, once the saturation up to 100, again the intensivist goes through the endotracheal. A lot of desaturation, hypoxemia is seen during these procedures. Okay, so what post-op care for these patients? So a normal recovery room for some time to these patients, they are shifted to recovery room. And a recovery room should be like our normal operation theater recovery room where we have all the emergency drugs, all the airway equipments, and a routine monitoring for at least for 30 to 40 minutes of your SpO2, your blood pressure, everything, and oxygenation if needed post-op for some patients is continued. Now, what are the complications seen during bronchoscopy? The most common complication is hypoxemia seen. It is because of the inadequate ventilation or some intrabronchial hemorrhage congestion due to some secretions. Second is hemodynamically instability. This is very commonly seen in ICU patients, high-risk patients. There are complications like airway obstruction, tension pneumothorax, and air emboli also. Laryngospasm and bronchospasm are not very uncommon. They are routine. They are seen sometimes. This hypoxia and hypercarbia can also precipitate to cardiac arrhythmias. Lignocaine toxicity is seen when the dose of the spray of lignocaine is on the higher side. Aspiration pneumonia, yes, sometimes it is seen. Technical complication in foreign body removal through this flexible bronchoscopy. So when the chest physician is removing the foreign body, sometimes the foreign body slips into the trachea. So it causes complete obstruction. So best is to push the foreign body back into the bronchus and re-attempt again. Sometimes the foreign bodies are sharp. So best is to advance the bronchoscope over the foreign body and pull it out so that the mucosa is not hampered. And if the foreign body is large, better is to proper grasp a better grasping instrument, and then it should not slip again. Next. Okay, so there are some studies I was seeing on the net. This is one is evaluation of bronchoscopy complication in a tertiary health center. There they had seen a 400 adult patients between 16 to 18, 5 years. The complications were seen in 13 patients, including bleeding 4 cases, pneumothorax 3 cases, collapse 4 cases, and infection 2 cases. So the rate of complications is very less. It is usually the minor complications are minor and self-limiting, but these complications are seen. It is not very rare to see all this collapse and bronchospasm, laryngospasm. Next. Few complications which I could find on this journal. This is a journal in 2022. Fatal air embolism, a complication during diagnostic flexible bronchoscopy. Next. Pneumotocele, a complication of bronchoscopy, a case report. This was in journal in 2007, Journal of Bronchology. Next. Hemotympanum post bronchoscopy, an unusual complication. Respiratory Medicine Journal, 2020, recent. Next. Subconjunctival hemorrhage, a case report, 2015. Next. Cerebral arterial air embolism. This was new for me also. I've never heard about such complications. When going through the net, I could find all these case reports. 2018 published. Next. A rare complication during flexible bronchoscopy where the patient had pneumomediastinum, pneumopericardium, pneumoperitoneum, interstitial lung emphysema, and some subcutaneous emphysema. I had seen such complication once during my residency where a double Lyman tube was attempted by a junior resident. Okay, so final conclusion is ideally bronchoscopy, if whenever possible, should be done in the OR operation theater. Airway equipments and emergency drugs should always be available. Adequate infrastructure and trained staff. Monitoring should be similar to our operation theater. All the basic monitoring should always be done. It is a team effort to obtain an optimal condition for safe anesthesia and successful procedure. We all should remain vigilant and familiarize ourselves with the NORA environment. Okay, thank you.
Thank you, Dr. Praveen, for navigating us through a bronchoscopy case virtually. We could imagine actually doing the case. We are going to take all the questions and queries at the end during panel discussion. Audience can write their questions in the chat box, and pertaining to their topics, we will let the speakers and panelists answer all your queries and doubts. So after bronchoscopy, the next venue for NORA will be a CT MRI suite. So I take the privilege to welcome our senior faculty, Dr. Varsha Vora Madam, to guide us to how to anesthetize a patient for CT MRI and discuss the complications and medico-legal aspects of the same. Over to you, Varsha ma'am.
Good evening, friends. Today my topic is anesthesia for CT MRI. Is my screen is seen?
Yes,
Hello?
it is seen. It is seen. You can do it full screen.
Full screen. This is full only, ma'am.
Okay, ma'am.
Yeah. Today I'm discussing about anesthesia for CT MRI, and topics for discussion are introduction to MRI, MRI room, hazards in MRI and its precautions, personal safety, anesthesia equipment, population group requiring anesthesia, anesthesia techniques, emergency and MRI room, post-procedure care, and summary. What is MRI? Magnetic resonance imaging is a medical imaging technique used in radiology to form pictures of the anatomy and the physiological process inside the body. MRI scanners are strong magnetic fields, magnetic field gradient, and radio wave to generate images of the organ in the body. Compared to CT, MRI provides better contrast in images of tissues. MRI is a non-invasive diagnostic technique that uses magnetic properties of atomic nuclei to produce high-resolution, multiplanar cross-sectional images of the body. Hydrogen is the atom mostly used for imaging. Hydrogen atoms are naturally abundant in human and other organisms, especially in water and fat. For the reason, most MRI scans essentially map the location of water and fat in the body. Pulses of radio waves excite the nuclear spin energy transmitted at magnetic field gradient to localize polarization in space. Now, this is parts of MRI. These are the parts of MRI: patient table, radio frequency, gradient coil, magnet, scanner. Then types of MRI and strength. Types of MRI, they are open MRI and closed MRI. There are 0.5, 1.5 and 3 Tesla machines. Types of images are T1 weighted, fat appears bright and water dark and provides a good gray-white contrast. T2 weight, fat appears darker than water, identifies tissue edema clearly. Thus, CSF is bright on T2 and dark on T1 weighted images. There are 4 zones of MRI. Zone 1 is where the reception and patient coming. Second is patient dressing and holding. Third is a computer room and a control room. And fourth is the main MRI chamber. Now, what are the hazards? In MRI, many people do know about MRI things. So, maybe a theory part is a little more projectile effect, movement and heating of implantable surgical devices and foreign bodies, effect of metals and other objects on the image quality, thermoregulatory issues, heating and heat loss, monitoring difficulties, minimal patient access, MRI chamber pollution by anesthetic gases, intravenous contrast agents, noise levels and other physiological effects, and quenching of MRI magnet. What is the first thing? You can see. All ferromagnetic atoms brought within the 50 Gauss line will be subjected to movement and may be rapidly accelerated into the magnetic field. Objects that are not fixed down, therefore risk becoming dangerous projectile and most cause injury to anyone in their path, as well as damage to the equipment and interference with the MR image generated. So before entering the control area of examination room, there is need to remove all ferromagnetic material. Solution to this is replacing machine ferrous material with stainless steel, brass or aluminum. Such personal attire for pens, needles, vials, scissors and other objects that are ferromagnetic. Install a test magnet outside the scanner room. Safe metal include nickel, stainless steel, alloy, titanium and titanium. To avoid and to detect this problems with implanted object, the anesthetist should move the patient slowly into and out of the field before induction and respond quickly to any reported sensation. Precaution. All personal equipment should not be carried to MRI room. Replacing ferrous with aluminum and steel. MRI checklist for patient, which is the checklist available about any pacemaker or any artificial things which is in the body. Movement and heating of implantable surgical devices and foreign bodies. Implanted ferromagnetic objects may also heat up significantly during the MR examination, causing local tissue damage. Absolute contraindication to MRI include cochlear implants, intraocular metallic, foreign bodies or sharpnail or particularly ferromagnetic arterial or anesthesia clips, which is neurovascular. Most modern patient implant, including metal prostheses, are non-ferromagnetic. General surgical clips, artificial heart valves, and sternal wires are usually deemed safe since they are fixed to the fibrous tissue. These are the things which is there on the door of MRI entry point, and do not enter with this following items. Thermoregulatory issue, heating and heat loss. Scanning room must be shielded from outside radio frequency interference, which may affect radio frequency transmission and reception. Any cable or leads can behave as antenna for radio frequency and must be shielded because radio frequency pulses may induce electric eddy current, short-circuiting electric equipment, or causing patient burns. Solution: aluminum foil to wrap cables and small copper boxes to isolate electric equipment. Lining the walls and window with thin continuous sheet of copper and by using waveguides in the wall. Specific absorption may be reduced by changing the pulse sequence, decreasing the number of slices, lengthening the repeat time, decreasing the RF scale, and switching to a smaller transmitter coil. Intravenous contrast like gadolinium D-megulamine used to increase the signal intensity on T1 weighted scans and reduce the signal intensity on T2 weighted scans. Has minor side effects including nausea, vomiting, and pain on injection. Rare complication of gadolinium called nephrogenic systemic fibrosis or nephrogenic fibrosing dermatopathy, seen and associated with renal impairment. Anaphylactic reaction is reported. For that, we have to be ready for that. Noise levels and other physiological effects. Noise levels above the safe level of 85 decibels can be produced during MRI due to the rapid switching of the gradient coils. Sound alarm to be accompanied with visual alarm. Solution: permissible exposure to noise of this level should be limited to 2 hours per day. Wearing earplug to be made mandatory for staff and patient, whether anesthetized or not. Equipment. Equipment is used in MR unit may be designed MR safe, conditional, or unsafe. MR safe device pose no non-additional MR related hazard in any MR environment. MR conditional equipment pose no hazard in a specific MR environment during specific condition of use. MR unsafe equipment known to pose a hazard in all MR environments is designated. The equipment must meet the 3 criteria. Pose no danger to the patient either by spontaneous movement within a magnetic field or overheating. Has no effect on procuring good images. Ferrous metal next to the atomic area being scanned will distort the image. Functional properly within the magnetic field, not on ferromagnetic circulatory. ECG introduces problem with both image degradation from wire leads acting as antenna and the inability of the ECG monitor to disconcern the ECG from the static magnetic field and radio frequency pulses. Impossible to reliably monitor for ischemia or to interpret arrhythmias. Use high impedance braided short leads and MR safe electrode placed in a narrow triangle on the patient's chest. Locating the electrolyte close together ensures a high amplitude signal. MR safe electrode use fiber optic cables transmit the ECG signal by means of a light rather than electric current. ECG electrode made of carbon graphite, lower resistance, eliminate ferromagnetism and minimal RF interference. Maintain the plane of any loop of cable parallel to the magnetic field lines. In patients highly susceptible to ischemia, a 12-lead ECG pre and post MRI is recommended. These are the ECG placement. There is a good placement and a bad placement. Oximetry. Severe burns to extremity have been caused by the induction of current within a loop of wire. These monitors are susceptible to interference from the changing magnetic field and will occasionally be briefly deactivated by RF pulse. This may be avoided by placing the sensor on the extremity distal to the magnet, keeping its wire free of the coils and protecting the digit with clear plastic wrap. Most monitor may be placed within 2 meters of the magnet. Alternatively, MR-specific pulse oximeter use heavy fiber optic cables which do not overheat and cannot be looped. Blood pressure. MR-approved monitoring system use automated osmotic blood pressure monitoring which, because it is based on pneumatic principle, avoids electromagnetic interference. Disposable transducers have a predictably high natural frequency, so tubing added to distance them from the patient is unlikely to cause damping. Anesthesia machine can be modified for use in magnetic field by replacing their ferromagnetic component to less than 2% of the total weight. Currently, MRI compatible machines made largely of stainless steel, brass, aluminum, and plastic. Aluminum cylinders replace ferromagnetic one on the anesthesia machine. They are pneumatically driven, fluid controlled, and volume cycle. Vaporizer are affected little by the magnetic field and function accurately within the magnetic field. Long bypassal D circuit provide oxygenation and ventilation. Lightweight, portable, flexible, and provide tactile sensation regarding the patient's airway and ventilation. It is also useful during transportation. Alternatively, total intravenous anesthesia necessitating use of infusion pump. Pump must be supported on non-ferromagnetic pump. Plastic battery-operated laryngoscope may be used for tracheal intubation. Coordination with staff. Anesthesists should work in collaboration with radiologists, technologists, staff nurse, and physician. Education should include how to safely respond to code blue situation in zone 3 and 4, and this information should be integrated into protocol for designated code blue team. The anesthetist should communicate with the other anesthesia team member regarding individual role for anesthesia care, and other team members should be informed in case of any emergency occurs. Need to keep ICU nearby MRI center in loop to shift patient in need. Patients requiring anesthesia. Infant and children with neurological disease, muscular malformation, and oncological tumor growth. Children and adult with learning disorder, patient with severe movement disorder, patient with position is limited by pain, claustrophobic patient, ventilated or other ICU patient, certain patients undergoing stereotactic neurosurgical procedures. Patient screening. Age-related risk, especially neonates and premature infant and elderly. Health-related risk for any comorbidities. Need for intensive or critical care. Impaired respiratory function. Comorbidities, they may contribute to adverse MRI effect, increasing burns or temperature increase in patient with obesity or peripheral vascular disease. PAC. Patient should be evaluated a day or two prior to procedure. Always check consultant paper and be in touch with him about vital parameters. Proper history, especially in children, of birth history, milestone history, any congenital anomaly, NICU admission, history of convulsion, or any operation during past. History of URTI, respiratory infection. In adult, additional history of comorbidity and effort tolerance to be noted. History of any device placement in the body. Pre-procedure investigation and advice and taking informed consent. Always confirm the above details on the day of procedure also. On procedure day, each case should be, however, be evaluated on merit for anesthesia. Often, conservative technique will succeed in preparing the patient for MRI investigation. This technique includes behavioral method like reassurance, advice, natural sip method like the feed and wrap method, and sedation. Apart from careful patient selection, and very few data exist to support specific anesthesia technique. One study suggested the addition of dexmedetomidine to propofol for sedation, which resulted in lower propofol requirement and airway complication. Preparation. A clean line of sight of patient and physiological monitor by direct observation. For positioning, the anesthesiologist should take into account potential electromagnetic and auditory results. Emergency equipment and drugs are immediately accessible. Emergency communication 4-out button is immediately should be available. An evacuation plan is in place, including appropriate location outside the scan room zone for resuscitation. Complex airway management should be performed in a controlled environment outside zone 4. Alternative MRI safe conditional airway device along with suction should be available all the time, like IGL and LMA. Sedation. That's the combination of drugs. Previously, we used to use oral chloral hydrate, but now we use a combination of midazolam, ketamine, or dexcade, or propofol. In the dose of midazolam, 0.05 to 0.1 milligram per kg, ketamine 1 milligram per kg, dexmedetomidine 1 microgram per kg, propofol 2 microgram per kg, slowly diluted, given with care. And all this should be diluted properly, peacefully in a pediatric patient and given slowly. General anesthesia should be induced in a dedicated anesthetic room adjacent to the MRI scanner. This provides an area in which standard anesthetic and resistor equipment can be stored and used. The location of anesthetic room should be such that patient can be easily and rapidly transferred and rapidly retrieved in an emergency. Patient should be transferred on MR-safe non-ferrous stone. Mask with non-ferromagnetic component must be chosen. The pilot balloon of a cough endotracheal tube contains a small permeability spring, and this should be tapped away from the area of the skin. And that's why many times LMA or IGL is used to avoid this. Maintenance of anesthesia can be achieved through IV. TIVA, it should be administered by using MR safe at conditional pump in zone 4 and traditional MR unsafe pumps in a zone 3 with intravenous tubing passed through a waveguide or given slowly IV diluted, very much diluted. Emergencies in MRI room, medical emergency like cardiopulmonary arrest and environment quench, fire and projectile. Medical imaging, immediately remove the patient from zone 4 while initiating CPR if indicated. Call for help. Transport the patient to a previously designated safe area for resuscitation that is not in zone 4. Resuscitation equipment, vital signs, monitors and card that include resuscitation drug, airway equipment, LMA, IGL, oxygen suction and defibrillator. Fire. When a fire occurs in MRI, team members should perform their pre-designed fire management tasks as quickly as possible in accordance with local guidance. Teamwork is the most important thing in this. Previously, we've seen that a patient who has stuck an oxygen cylinder, this has been reported before. And for this, what is there is quenching. Quenching is an emergency magnet rundown unit. This initiates a control quench and turns off the magnetic field. It is typically a big red button located on the wall of the magnet room near the door. It may be labeled magnet stop or emergency rundown. This button should only be used in a life-threatening emergency such as a patient pin in the scanner by a metal object or a fire in the magnetic threading. Initiating an emergency quench is a serious proposition, placing the scanner out of service for a week or more, potentially damaging the magnet and costing it lakhs or more to replace the lost liquid helium. And it causes the environmental problem also. Recovery. Keep patients in recovery position. Monitor for 1 hour. MBM for 2.5 to 3 hours. Watch for vomiting or other complication. Contact number in case of problem. So take home message is understand your workplace. Prioritize patient safety. Tailored anesthesia. Effective communication is the key. Continuous vigilance is an important thing. Thank you. And these are my references.
Thank you very much, Varsha Vora madam. It was a very concise talk because finishing CT and MRI both in 20 minutes is very difficult. And thank you for giving us a comprehensive
I
gist.
just want to mention that I read ASA 1 or 2, 3 and 4 are sent it to a bigger hospital, corporate hospital.
Ma'am, we will take the questions and doubts at the end of the
Okay, thank you.
session. So we move to our next topic for today. For this, I would like to invite the next speaker. Our next topic is anesthesia in GI endoscopy suite. And the next speaker is Dr. Rajan Daftari sir, who is a consultant anesthesiologist, GI endoscopy and pulmonology in Gleneagles Hospital, Parel, Mumbai. So Global Hospital is now Gleneagles Hospital. He has many accolades to his CV. So he is a professional position held is he's a consultant. He was a consultant anesthesiologist at Breach Candy and Messina Hospital. He was a scientific committee chair, Mumbai Anesthesia Society 2010 to 2015. He has received first rank in MD anesthesia exam, and he has received Moxmadan Desai Gold Medal from University of Mumbai. He stood first in diploma in anesthesia in Mumbai University in 1983. He has delivered over more than 60 lectures, conducted numerous panel discussions on wide-ranging topics including labor analgesia, minimal invasive surgery, CPR training, and workshops for paramedics. He has conducted over 12 international workshops on advanced GI endoscopy from Global Hospital and has one of the largest experience in non-operating room anesthesia. He has been involved in microlaryngoscopic procedures, bronchoscopies, rigid and flexible scopies for diagnostic and therapeutic, including metal stent placements for strictures of fistulas. He has few publications under his name. So we welcome you, sir, and we would like you to take us to the new venue, that is a GI endoscopy suite. Over to you, sir.
Dr. Daftari, you need to unmute yourself.
Daftari sir, please unmute yourself.
Daftari sir, please unmute yourself.
Maybe someone should call him and tell him.
Ma'am, I'm calling him. Hello. Sir, you will have to unmute.
Okay. Can you hear me now?
Yes, sir. Yes, sir.
You
Welcome,
can hear me?
sir.
Okay.
Yeah.
I'll share my screen now. Can you see the screen now? Can you see the
Yes.
slides?
Yes, sir.
Okay.
You can do full screen.
Yeah. Am I okay now? Renu, are you able to see the whole screen?
Yeah, but you can, no, it's not whole screen.
No, this is the whole screen here.
Okay, sir.
Okay. So quickly getting into the topic because it's an enormous topic and I'll try and see what I can tell you in 20 minutes. The question that a lot of people ask is sedation really necessary? And the answer to it is a solid yes, because not only for the advanced procedures, but even for GI endoscopy or a colonoscopy, if you want to do a good job, not miss some small lesions, do a thorough procedure, you need to have sedations. And there are so many agents that all of you are aware of, so we'll not waste time over there. And as far as the spectrum in endoscopy is concerned, it has become so vast that I would strongly want to believe that soon this is going to become a super specialty by itself, where just as you have cardiac anesthesia, neuro anesthesia, pediatric, you should be having endoscopic anesthesia. So that's how big the topic has become today. So, what are the goals when we are doing GI endoscopy sedation? So you want to alter the level of consciousness, allay the anxieties, maintain an intact airway and protective airway reflexes. This is most important. Okay. Primarily, don't forget that we are over there to aid somebody to do a procedure. Yeah, we are not by directly doing any therapeutic work. So the last thing that should happen is a complication as far as the airway is concerned or something like an aspiration. Maintaining hemodynamic stability, inducing amnesia because a lot of these patients keep on coming repeatedly for their procedures. That's the nature of their illness. Having a very cooperative patient helps the endoscopist to do a good job. And finally, returning the patient to a predetermined state is the key to what we do. So a lot of people say, well, how much sedation? Is it mild, moderate? My answer to that is please do not use those terminologies. They are highly outdated. We should be saying that we are doing monitored anesthesia care. So it's nothing but a specific anesthesia service in which an anesthesiologist has been requested to participate in the care of a patient undergoing diagnostic or therapeutic procedure. Okay, so that encompasses everything. whether it is sedation or whether it is you need to give general anesthesia, for example, your patient with full stomach, it is still covered by your monitored anesthesia care. So what are the issues? The issues are patient related, age related, extremes of age.
Sorry to interrupt, Dr. Rajan Daftari.
Yeah.
The screen is not, slides are not moving.
Slides are not moving.
Yeah, now we have the patient-related issues slide.
So now your slides are
Now you
moving.
are, yeah.
Now is the slide moving?
It is showing patient-related issues now.
No, I've gone to the next slide. It's not moving.
No, not yet.
No, sir.
Ganesh, can you help them?
Yes, madam. Sir, reshare your screen.
So could you just stop screen sharing and restart screen sharing?
Yes.
That would help.
So you will see a red icon.
Yeah.
Okay.
Kamala madam has typed that please go on slideshow.
Okay, is it moving now? Are the slides
No.
moving?
No, sir.
No,
So
sir.
at the top, there is slideshow. You can go to that, sir. Slideshow.
Okay, so I'll stop sharing again.
There is an option of slide control in the right upper side on the panel. Control slide movement.
Sir, click on slideshow.
If I go on the slideshow, it will go at a fixed.
From beginning, first option.
Okay.
Yes.
Is that okay?
सर फिर से क्लिक कीजिए वहाँ पे फ्रॉम बिगिनिंग पे.
Yeah. So is the slide moving now?
No, sir.
Not yet, sir.
Okay. Retrying something.
The other option is on the left-hand side. You can click on the slides, individual slides, and go.
Okay. I can do that. Let me see. Okay.
Yes, sir. Now it's showing. Yeah.
Yes, sir.
Now it's moving.
Yeah.
Yes.
You'll have to click on the individual slide now, sir.
Yeah. So basically, I'll do it like that.
Yeah.
Right. Okay. So let's go back to where we were, and I think you heard the goals of the sedation. So let's not waste time over there. Yeah. So we have patient-related issues, extremes of age, pediatric age group, geriatric age group, or multiple comorbidities, all systems that can be possibly involved. We see all patients coming with that. Multiple drugs, be it antihypertensives, diabetics, antiarrhythmics, and in today's time, a huge number of patients on antiplatelets or anticoagulants. Obesity, of course, remains one major issue in our endoscopic situation, primarily because of the airway issues. Pregnancy, they do keep on coming, and so problems over there. And finally, the emergencies that we see in our center, 3 of them today landed up. GI hemorrhages, they can really stretch you to your limits. Cholangitis, where the patient is very sick and the cardiovascular system is very unstable. So in elderly patients, basically what we have found is that there are some pharmacokinetic changes. They have a lot of comorbidities, but still most of them tend to do reasonably all right, so long as you understand what drugs you are using and what dosages you are using. Some amount of confusion in the immediate post-procedure period is to be anticipated, and I do counsel about it to the patient and the patient's relatives, and so it is quite acceptable. Pediatric patients, again, we see a large number of them, more often because of biliary problems, biliary atrasias, upper GI bleeds, and of course foreign bodies. They do keep on coming to us. We've done a fair number of pediatric ERCPs also, pediatric colonoscopies for rectal bleeds. So these are the issues with pediatric patients. The pediatric airway, as all of you who are doing pediatric cases, you know, they are more prone to hypoxia and hypoventilation during procedural sedation, partly because they are obligate nose breathers. They have relatively large tongue. The tonsils and the adenoids are hypertrophic very often in them, and they have a large floppy epiglottis, which makes the thing more difficult. Pregnant patients, one of the things that I follow is that if possible, try and avoid doing bigger procedures up to second trimester. Somebody comes in the 10th week and says that they've got a CBD stone. Well, they can be managed as far as pain is concerned. Wait till 12 weeks are over so that most of the organogenesis is done, because the problem is the fetus can be endangered by the heterogeneity of the drugs, of hypoxemia which can happen, or hypoperfusion which can happen. So therefore it is ideal to get these patients up to the second trimester. As far as radiation is concerned, we try and avoid using CM even for ERCPs, because of the high number of cases that we have done. We can get away with it. We just go by feel. We see that the bile duct is cannulated by aspirating bile and continue with the procedure. Very rarely the need of tocolytic drugs comes into play, only for advanced pregnant patients. There is a provider related issue, and that is that there are no standardized protocols for what we are supposed to be doing. The depth of sedation is not clearly defined. There is a communication gap between the endoscopist's need and what we are trying to give. Surely the lack of training is very obvious. So therefore, if you are an occasional anesthesiologist in a GI endoscopy suite, you will find that it is more difficult. The need to continuously adapt, learn, and collaborate is very important. The need for good recovery and training nurses is also very important, because you need a good support system, and the discharge criteria can be well defined, should be well defined. What are the indications for monitored anesthesia care in GI endoscopy? Those who have ASA class 3-5, the extremes of age, as I said, serious comorbidities, those who have compromised airway, like those who have snoring, sleep apnea, stridor, severe obesity, dysmorphic facial features, small mouth opening, protruding incisors, macroglossia. Situations which need deep sedations, like in psychiatric patients, those with dementia, complex ERCPs, EUS with FNACs, upper GI stenting, therapeutic procedures for severe bleeding, and others like those who are dependent on opiates, sedatives or hypnotics, drugs, or alcohol abuse. Previous history of problems with sedation also is an important criteria to remember. Preparation and setup. All of you are aware of this. The acronym SOAP-ME tells you everything. We'll not spend time over there, but please do not compromise on any of these things, including a separate suction for yourself, a steady source of oxygen, all the airway adjuncts, drugs for sedation and for basic and advanced life support if the need arises. The multi-para monitor is a must, and resuscitative equipment should be available with the thing. What about pre-procedure assessment? This is the key to produce consistently good results in endoscopy. Treat these patients like how you would treat a surgical patient. A quick history, find out what medications are they taking. Starvation history, very important. Ensure that they are adequately starving. Otherwise, you will definitely land up with an unnecessary complication. Taking an informed consent remains our duty, and we should be aware about it, and it should be documented well. A quick cardiovascular and a respiratory examination so that you don't miss on anything, and then we go on further. Now, these are some of the drugs which are newer additions to what we were using before. Dexmedetomidine has been a good drug to be used, especially in prolonged endoscopic procedures. For example, we do enteroscopies where we take about an hour and a half to 2 hours to examine the small bowel, or we are sometimes doing extracorporeal lithotripsy for pancreatic stone disease. Dexmedetomidine is really a wonderful drug as far as that is concerned. I don't find it to be so much useful in our routine OGD scopies or colonoscopies or ERCPs, but otherwise it's good. Remifentanil, I've still not managed to use it, but I'm not too excited about it by sheerly looking at all possible side effects. I think it demands too much of attention to it, and I don't know whether that's possible when so many other difficult things are going on in the endoscopic suite. Supplemental oxygen to the patient should always be given, even if you are doing under TIVA. Please do not compromise on that. There is a problem about that, as you will see in the slide further, where they say that if you're giving supplemental oxygen, it may delay the recognition of hypoxemia and apnea if it occurs, and therefore that much valuable time is lost. However, having said that, still oxygen supplementation remains absolutely must. The glyceryl trinitrate spray, which is available, is an excellent device for managing sudden shoots in pressure. Especially, you suddenly find that the pressures have gone up just prior to a sphincterotomy. A single spray of that glyceryl trinitrate in the nasal mucosa or in the oral cavity, and you can find that the pressures are dropping down. What about 10% lignocaine spray that everybody uses? I personally don't use it at all because I don't think there is any role for it when you are giving adequate sedation. One of its biggest problem is immediately post-procedure, the patients complain of difficulty in breathing or choking. It's purely because the respiratory receptors have been blunted. The relatives keep on complaining that he's not able to breathe while your oximeter tells you a completely different story. So you can get away without using lignocaine 10% spray, and that solves the problem of how soon you can give them something to drink post-procedure. What about hyoscine? Remember, it's a drug you use very often to reduce the contractions of the small bowel when they are doing cannulations of the bile duct or the pancreatic duct. It has a tendency to produce significant tachycardia, which is detrimental in ischemic heart disease patients, and hypotension, which can also worsen the scenario. So therefore, use it very carefully and monitor your patient well. Again and again, I would like to emphasize that the endoscopy suite should be well equipped so that the procedure and anesthesia related serious complications can be very effectively managed. Monitoring, multipara monitors. If you have a capnograph, that is wonderful. However, with a nasal oxygen cannula, trying and keep the the nasal prongs for capnometer, you will find that your values are abnormally low. Doesn't matter. I look at it like this, that maybe you started with a capno reading of 22, and what is more important is it is giving me the respiratory rate. So I would immediately know when the rate starts dropping. Of course, if you have connected your cardioscope leads, that also in most of the monitors gives you the respiratory rate. So that would help you in preventing missing out on hypopnea or apnea in your patients. The American Society of Anesthesiology is very strongly trying to push capnography as an absolute must in endoscopy because they see a fair number of hypoxic injuries, and it is their number one complication. I strongly suspect it is their number one complication because a fair number of procedures are done by nurse anesthesiologists and not like all of us over here who are trained to see small things and pick up things very early. When do you do endotracheal intubation in GI endoscopy? Most of the procedures do not need it. And I don't think the duration of the procedure is the one which is going to decide whether you need endotracheal intubation. For me, anybody who's got very severe GERD or who's got a full stomach, a pediatric patient undergoing prolonged procedure, somebody who's got very bad sleep apnea, or you are doing an advanced procedure like peroral endoscopic myotomy for achalasia cardia, or you're doing a cystogastrostomy for a large pseudocyst by placing a metal stent into the pseudocyst. These are procedures, and of course, the more common severe upper GI bleed, as I told you, where intubation is a must to protect your airway. The common problems that we encounter in GI endoscopy is hypotension or hypertension. Hypoxia, as I said, is more common because if you do not do the chin lift jaw thrust maneuver correctly, the person holding the mouthpiece is an important part of your team, and he or she should be trained how to do that. You could have respiratory depression or arrest because of whatever drugs you're using, especially if you're using narcotics. So be careful about that and look at your monitors. Regurgitation, vomiting, and aspiration is very, very critical. And for this, I always tell that a good history is very important. I have a patient who is coming for an endoscopy for repeated vomiting. I need to know whether she's able to retain anything at all or not. I should have a high index of suspicion that there is a possibility that she could be having contents in the stomach, though she has not had anything overnight. So she's got maybe a gastric outlet obstruction, maybe she's got a tumor in the head of the pancreas, which is not allowing food to go through. These are patients where if you do not guess it right, you could end up having regurgitation, vomiting, and aspiration, and it's sequelae. Sometimes the severe fluctuations in heart rate or blood pressure could precipitate an acute coronary syndrome. Allergic reactions, especially if you're used to using antibiotics during the procedures, can happen. Hypoglycemia, the newer oral hypoglycemic agents that have come into the market, I'm seeing a little more tightly controlled patients coming. So please be aware of the glucose levels before starting these patients for a procedure. And if they are borderline, it's not a bad idea to give them some dextrose, rather have some hyperglycemia than a hypoglycemic issue. So finally, when we talk about sedation complications, I discussed about respiratory depression. I talked about having a proper person doing a jaw thrust and chin lift procedure. And most of the times, the cause has been inappropriate amount of sedation, which causes this problem. So judging your dosage is very, very critical in preventing this sort of complications. Having a good post anesthesia recovery is vital to have a good outcome, because you may manage the patient very well intraoperatively, but if your post anesthesia recovery is not being taken care of by trained nursing staff, you could still have some difficulties. For example, a high risk patient could be having a tongue drop happening over there, or somebody who's deeply sedated may need a little more help, either in the form of an airway or some other device. So these nurses should be well trained over there. Preferably, one would like to have a doctor over there to take care of them. They should understand the discharge criteria, which are well taught to them. Proper written instructions are given to the patients during discharge regarding the starvation, regarding medicines to be taken, and regarding where to contact in case of an emergency. And an adult person should be accompanying the patient while going home. The Aldrich score is the one which all of us are following, and I think that works very well for all of us. So that's something to be used deciding when the patient can be sent home. Now, this slide is so important because in today's time, when everybody threatens us about medical legal issues, documentation is so vital. What all do you document? You document the informed consent. You document that you had examined the patient before and done a health evaluation. You would have written down the pre-sedation instructions, including the duration of starvation and maybe what drugs to be taken on the day of the procedure. For example, the antihypertensives to be taken for stopping the antiplatelets or the anticoagulants if they are on an adequate period. The time-based record of sedation score intraoperatively, the technique used, the drugs used, and the monitoring should be documented. And if any adverse events happened, should be mentioned and what treatment was given. The time and the condition of the patient at the discharge also should be very clearly mentioned in all your documents. We are seeing improved outcome today thanks to the smaller diameter endoscopes with superior optics, very well equipped endoscopy suites, large number of procedures which have made endoscopy's learning curve short, thorough pre-procedure assessment, instructions and starvation guidelines, superior drugs, anesthesia machines and monitors, and a well-trained staff which understands their own role to play in the whole thing. Thank you so much for this patient listening.
Thank you very much, Dr. Rajan Daftari sir. It was a privilege of all of us to hear from you. There are many questions. We will be taking all of them during the panel discussion at the end of the today's session. Yeah.
Sorry for all that confusion in the beginning.
No problem, sir. Thank you so much.
Pleasure.
Yeah. So we move on to our next venue for NORA today. So let me welcome Dr. Anita Shetty, madam, who is the professor and HOD of HBT Medical College and R.N. Cooper Hospital. She has numerous achievements. She was a neuroanesthesia fellowship coordinator from 2011 to 2021 at KEM Hospital. She was past president and past secretary at ISA Mumbai. She has more than 45 publications in national and international journals. And she's famous for being very helpful to all the medical students in the medical college. So we welcome you, ma'am, and let us hear from the expert on anesthesia and interventional radiology.
Thank you, Renu, for giving me this wonderful distinct introduction about me. And good evening. At the outset, I would like to thank the organizing committee of Borivali Society of Anesthesiologists for giving me this opportunity. And my topic, I'll do the screen sharing. Just my topic is anesthesia consideration for intervention radiology.
Ma'am, you can do full screen.
It's not full screen?
Yes, ma'am.
It's not full
madam,
screen, you know?
Not yet, sir. Madam, it was, but it has gone back again.
Acha, I'll do it.
Yeah, okay.
Yeah, now it's okay. Ma'am. Yeah.
My topic is anesthetic consideration for interventional radiology. The interventional radiology has progressed tremendously in the last few decades. Though it is called the minimally invasive procedures, it poses significant challenges to the anesthesiologists because of the complexity of the procedures performed, remote location of the intervention radiology suite, and some of the complications encountered in the intervention radiology suite are similar to those encountered in the operating room. Now, the goals of intervention radiology can be divided into three classes. One is definitive therapy, such as embolization of AVM, coiling of aneurysms, and embolization of bleeding ulcers. Adjunct therapy for surgery or radiotherapy, such as preoperative embolization of tumors to decrease the bleeding intraoperative period. And palliative therapy, like selective chemotherapy for inoperable tumors. Now, this is just a brief summary of the procedures which can be performed in the intervention. The list is endless. So just to mention the few, they can be vascular or non-vascular, diagnostic or therapeutic. Just to mention the few procedures: paracentesis, thoracocentesis, percutaneous drainage of abscesses, placement of chest tube, placement and maintenance of apheresis, dilation, infusion catheters, image-guided soft tissue and bone biopsy, percutaneous liver and kidney biopsy, placement of gastrostomy, gastrojejunal tube, varicocele embolization, embolization of gastrointestinal bleeding from the vessels. Then nephrostomy, nephroureterostomy, biliary drainage, cholecystostomy, renal artery angioplasty and stenting, venous thrombolysis, angioplasty and stenting, permanent and temporary cable filtration, dialysis access planning, percutaneous treatment of malfunctioning or thrombus dialysis access, transjugular intrahepatic portosystemic shunt. One second. Neurological procedures, which can be closing or occluding procedures or opening procedures. The closing and the occluding procedures are embolization of aneurysms, AV malformation, fistula of the brain and spine, preoperative embolization of vascular tumors such as meningiomas, temporary or permanent occlusion of vessels intra or extracranially, opening procedures such as treatment of vasospasm or stenosis by angioplasty and stenting, chemical and mechanical thrombosis in stroke, chemoembolization for liver tumors, radiofrequency ablation of liver tumors, kidney tumors, and osteomas, and stenting of malignant strictures. So as you can see, the procedures are numerous and right from head to toe. All the procedures can be done in the intervention radiological suite. This is the picture of an intervention radiological suite where you have the fluoroscopy at the head end. The intervention radiologist or the intervention physician and the scrub nurse stands on the right-hand side. The anesthetist stands at the opposite side, preferably at the leg end so that the radiation risk is reduced. There is a protective screen here, so the people who want to watch the procedures can stand beyond the viewing gallery or a console room at the foot end of the patient. Now, what are the general consideration when are you doing procedures? Whenever you do procedures in the intervention radiology suite, you should have long anesthesia circuits, IV tubing, monitoring cables and lines. So as you increase, so that the distance from the fluoroscopy is increased and there's minimal radiation, the radiation exposure is minimized. Secondly, when the patients are draped, the arms are restrained at the sides, and then to get the venous access, it's very to access the veins, venous lines is very difficult. Anesthesia machine, I told you, should be opposite to the radiologist, preferably at the foot end of the patient. Pressure transducers, IV poles, and infusion pumps should be mounted on the radiology table. Hoses for oxygen, nitrous oxide, air suction, and gas evacuation should be behind the anesthesia machine. And there should be enough space behind the anesthesia machine for cylinder checks, machine checkout, and monitor adjustments. What are the special concerns during the interventional radiological procedures? The radiology suit preparation, and as Dr. said, that you must remember the mnemonic SOAP-ME, that is suction, oxygen, airway equipment, drugs, and equipments and monitors, equipments like anesthesia workstation, defibrillators, etc. The radiology suit should be prepared as exactly as the same as the operating room preparation. Then ensure optimal protection from radiation. Since the image intensifier of the fluoroscopy is at the head of the patient, in emergency cases, it's very difficult to access the airway. Blood loss is not usually a problem, but sometimes a catastrophe can occur. There can be a bleeding from an abdominal aneurysms. And in such cases, the blood bank should be contacted and the blood should be immediately available. There are concerns about contrast reaction and ensure safe administration of sedation and analgesia. Now, the radiation used is ionizing radiation. This radiation can get absorbed into the body tissues and can lead to potential harm to the body. So the technique, the imaging method used in the IVR suite is high-resolution fluoroscopy or high-speed digital subtraction angiography, and this is primarily used to image the blood vessels. Now, there are three sources of radiation in the intervention suite. It can be direct radiation from the X-ray tube, leakage through the collimators, and scattered radiation from the patient's body. As we all know that the amount of exposure decreases proportionally to increase of square of the distance from the source of radiation. The DSA, there is more radiation than fluoroscopy. Actually, during DSA, what happens? There's multiple X-ray DSA, or during fluoroscopy, there's multiple X-ray beams bursts are produced. In a DSA, almost 12 to 25 X-ray beams can be provided per second. So as you can see from this table, during one interventional cerebral angiography, you are exposed to almost equivalent to 300 to 500 X-rays. The National Council on Radiation Protection and Measurements recommend that the limit should be not more than 5,000 milligrams per year. This is how you protect yourself from the radiation. So you should ensure that you have a wraparound aprons, lead aprons to be used. And this lead apron thickness should be at least 0.5 millimeter lead thickness equivalent. Then the additional protecting shields required are glasses, lead cap, thyroid shield, and even the protection scheme. Dosimeter badges should be used by all the staff in the radiology suite and should be sent regularly every monthly or quarterly for the checking of how much radiation you have been exposed to. The contrast can cause hypertonicity, direct cardiac depression, idiosyncratic anaphylactic reactions, and contrast nephropathy. Now, how do you decrease the incidence of contrast nephropathy is by limiting the dose of the contrast agent, use non-ionic low osmolar agents, and optimal hydration of the patient is important. Up to 300 ml of contrast can be used in one interventional procedure. The efficacy of N-acetylcysteine and IV sodium bicarbonate to prevent contrast, there is not much evidence that the N-acetylcysteine and IV sodium bicarbonate help in preventing contrast or reducing contrast nephropathy. Now, what anesthesia should we choose, whether it should be general anesthesia or monitored anesthesia care? That all depends on the multiple factors like patient, the complexity of the procedures, and the comorbidities. What are the advantages of general anesthesia? It ensures patient comfort and analgesia. Due to immobility, there is improved image quality, better airway control, better control of respiration and hemodynamics. The disadvantages are in neuroradiological procedures, you cannot perform the neurological assessment intraoperatively. And again, in neuroradiological procedures, during endotracheal intubation and extubation, if there is hypertension, coughing or straining, this can increase the intracranial pressure. So for general anesthesia, the intravenous agents used are propofol or etomidate. The choice of muscle relaxant depends on the need for rapid sequence induction. Airway can be LMA or the endotracheal tube can be used to get airway control. And precautions should be taken to prevent pressure response at intubation by opioids, lidocaine, labetalol, or esmolol. Now, monitored anesthesia care. What are the advantages? These monitored anesthesia care may be used in daycare surgeries, short procedures, or minimally invasive procedures. The main advantages in neuroradiological procedures, the intraoperative neurological assessment can be done. The disadvantages are that the airway is unprotected, where there can be risk of aspiration, especially if there is a bleeding gastric ulcer, and in patients with impaired GCS. Another thing is that the respiratory depression due to the sedation have the potential to cause hypoxemia and hyperkalemia. And in neurological patients, this can increase the intracranial pressure. Sudden patient movements can degrade the quality of imaging. And if there is an emergency, getting an access and securing the airway may be difficult because of the C-arm at the head end of the patient. The agents which can be used for monitored anesthesia care are propofol, midazolam, droperidol, opioids, ketamine, dexmedetomidine. They can be used as intermittent boluses, continuous infusions, or target control intravenous sedation. Now, certain regional anesthesia can be used like peripheral nerve blocks for peripherally located lesions. For lower abdominal and lower limb procedures, you can even use spinal anesthesia or continuous epidural catheters. Now, what are the pre-procedure considerations? As for any other patient, it's important to take proper history, evaluate the patient, physical examination should be done, laboratory investigations must be done, pre-medication and room preparations should be ensured. In history taking, it's important to note whether the patient has any concurrent illness and should be optimized prior to the procedures. The other history which should be obtained is previous history experience with angiography if the patient has history of prior anticoagulation or coagulation disorders, because intraoperatively anticoagulation can be required. And if they are prior on some anticoagulation, you have to be very careful when you do laryngoscopy, intubation, and suctioning. History of protamine allergy should be noted. History of recent steroid use should be noted because patient may require you need to supplement steroid in the perioperative period. History of contrast reaction. If the patient has a positive history of contrast reaction, we can anaphylaxis, then you may pre-treatment with antihistaminics and steroids may minimize these reactions. If the history of whether the patient has any neck, back, or joint problems, because if the patient has neck, back, and joint problems, this will influence the ability of the anesthetist to for airway management, and at the same time, whether the patient can tolerate in supine position for prolonged period of time under MAC. In the childbearing age group, pregnancy in female should be ruled out, and history of concurrent medications like anticoagulation, anti-epileptic steroids should be noted. In the physical examination, the relevant physical examination should be done. Know the pre-procedure neurological status. As I told you, if there's impaired GCS, the patient have increased risk of aspiration, and with sedation, there can be increase in ICP due to hypoxia and hypercarbia. And if the patients have predisposition to airway obstruction, if the patient is sedated, and they can they can have airway obstruction in the intraoperative period, and access to airway becomes difficult. Routine hematological and biochemical investigations and renal function test is important to know the serum creatinine because contrast can cause contrast-induced nephropathy. In selected patient, liver function test should be done. Blood sugar should be done. The coagulation system should be evaluated because anticoagulation is required in the intraoperative period. And certain patients like carotid stenting, aneurysms, or patients with having comorbidity like ischemic heart disease, hypertensive, ECG, and 2D echo also should be done. Anxiolytic and sedatives can be administered, but precaution should be taken when administering sedative to patients who have impaired GCS or lower level of impaired consciousness. Patients with subarachnoid hemorrhage may be on nimodipine, which should be continued to prevent vasospasm. H2 receptor antagonists like ranitidine and metoclopramide can be administered. And of course, if the patients and corticosteroids, anticonvulsant, they should be continued. And certain procedures like transjugular intrahepatic portahepatic shunt may require antibiotics because they can have infection in the post-op period. Now, after confirming adequate starvation and taking an informed consent, it's very important to make the patient comfortable for positioning because if it is done in MAC, they may be uncomfortable lying supine for a prolonged period of time. So you should use air mattresses or foam and devices to position the head and the neck properly. For intravenous accesses, one large gauge, sometimes two IV accesses can be taken. So one to give infusion and one to give the bolus of the drug. Then arterial pressure monitoring may be required when manipulation of the BP is required in certain intracranial procedures. So the radial artery can be cannulated or the femoral sheath can be used to monitor the blood pressure. When you use the femoral sheath for monitoring the blood pressure, the systolic blood pressure is underestimated and the diastolic pressure may be overestimated, but the mean arterial pressure doesn't change much. If the patients for neuroradiological procedures and have there is a tendency for ischemia or thromboembolic complications can occur, then CNS monitoring may be required like EEG. So electrophysiological monitoring like SSCP, motor evoked potential, transcranial Doppler, and cerebral blood flow monitoring. Then standard ASA monitors like 5-lead ECG, NIBP, pulse ox probe, ETCO2. It's very important to monitor the temperature. It's important to keep the temperature as normal as possible because the patients can have hypothermia due to the ambient temperature or when the lot of flushes, cold saline flushes are used. Shivering can degrade the quality of imaging. And one thing important to remember when you use a pulse oximeter probe, you can put the pulse oximeter probe on the toe in which the femoral sheath is introduced, which will give you a warning sign. If there is a fall in saturation, it will give you a warning sign that there may be occlusion or some thromboembolic complications of in the femoral artery. Bladder should be catheterized, as I've told you, that a lot of saline flushes are used, and contrast can cause osmotic diuresis. And blood glucose monitoring is important, especially in neurological procedures, because you have to maintain normoglycemia. For the endovascular procedure, the radiological, for the arterial route, you can use retrograde or antegrade femoral artery puncture, or even the radial or the brachial artery can be used. The problem with the radial artery is you cannot use large femoral sheaths. Venous access for the procedures can be accessed through the femoral or the internal jugular vein, and certain venous angiomas and malformation, you can directly inject the ethanol. Direct percutaneous puncture is done to inject the for sclerotherapy. Now, usually after infiltrating local anesthesia, 7.5 French sheath is administered into the femoral artery, and through this, a 7 French coaxial catheter is introduced, which is placed at the carotid or the vertebral artery under fluoroscopic guidance. And finally, 1.5 to 2.8 microcatheters are inserted to progress to the distal circulation for delivery of drugs, embolic materials, and balloons. So as you can see, you have a femoral introducer, then a coaxial catheter, and finally a microcatheter for delivering of drugs and embolic materials. Now, what is the imaging technology used in interventional radiology suite in INR procedures? Especially, we take a scout film, and scout film is taken before every DSA run. This serves as a mask, and this is done to remove the bony shadows and other non-vascular structures. So what you get is, and this image is then subtracted from subsequent images, and then you get what you see is only the opacified vessels. And then there is a technique called road mapping, so where you can see that to facilitate passage of catheter into the distal circulation. So you inject the contrast dye and get an image of the vasculature, and this image is then superimposed on subsequent fluorescent images, fluoroscopic images by the computer, and you can see the passage of the catheter. As I told you, anticoagulation is very important to prevent thromboembolic complication. So get a baseline ACT. Heparin is given at the dose of 70 to 100 units per kg. After this ACT after giving heparin, do the ACT after giving heparin. It should be at least 2 to 3 times the baseline ACT. After every hourly, repeat the ACT, or sometimes empirically, 2000 units of heparin are given every hourly. But if the procedure is aborted before the foreign material deposition or lesion, or not amenable to treatment, or if there is an hemorrhagic complication, then the heparin should be reversed with protamine. It's very important when there is hemorrhagic complication to immediately reverse with protamine. So protamine should be always available on the trolley. 1 milligram of protamine will reverse 100 units of heparin. Now, the complications in neuroradiological procedures can be hemorrhagic or occlusive. Hemorrhagic complications are due to aneurysm perforation, vessel injury or dissection. Occlusive complications are, as I told you, if there is perforation or vessel injury, heparin should be immediately reversed. Occlusive complications are thromboembolism, coil displacement, coil fracture, and vasospasm. In these patients, it's very important to give deliberate hypertension so that the collateral is maintained. The other complications are similar. Many of the complications are similar to any of the radiological procedures, intervention radiological procedures like contrast reaction, nephropathy, groin hematoma, retroperitoneal hematoma, cardiopulmonary collapse, post-embolic syndrome, urokinase chills, and normal perfusion pressure breakthrough. I'll explain to you what is normal perfusion breakthrough in the subsequent slides. Now, what are the primary anesthetic considerations for the certain intervention neuroradiological procedures? So, what are the commonly performed procedures performed in the intervention neuroradiological procedures performed in the interventional suite? So there can be therapeutic embolization of vascular malformation. For intracranial AVMs, you may need to give deliberate hypotension, and there is a concern of post-procedure normal perfusion pressure breakthrough. Deliberate hypotension of flow arrest is required so that the glue doesn't go into from the arterial circulation, where it should be placed exactly in the needle. You have to take care that the glue doesn't go into the venous side of the circulation, because this can result in pulmonary embolism. And therefore, you need to arrest the flow or reduce the flow. Now, what is post-procedure normal perfusion pressure breakthrough? When there is an AVM, there are chronically hypoperfused area. There is a chronic hypoperfused area. And suddenly when you restore the circulation, the autoregulatory capacity is overwhelmed, and there can be hemorrhagic complications of cerebral circulation. So important to keep the blood pressure 10 to 20% below the baseline in the post-operative period to avoid this complication. During day with dural AVM, when you're doing certain, what are the primary anesthetic consideration during day with dural AVM and extracranial AVMs. In dural AVM, there can be venous hypertension can be present, which can increase the intracranial pressure, or there are chances of ischemia, and deliberate hypercapnia may be required. How does deliberate hypercapnia help? Is deliberate hypercapnia causes vasodilatation and increases the intracranial venous outflow. So it prevents the embolizing material from entering in from the extracranial vessels entering into the intracranial circulation. Now, for carotid cavernous fistula, again, that deliberate hypercapnia may be required, and there are concerns of post-procedure normal perfusion pressure breakthrough. In aneurysm, one must keep in mind that there can be aneurysm rupture. How do you diagnose aneurysm rupture? You can see the extravasation of the dye in the vessel, or there can be sudden increase in intracranial pressure, so there can be bradycardia hypertension. And so, as I've told you, it's important to immediately reverse the heparin with protamine and keep the blood pressure into the normal levels, and do not allow the blood pressure to increase. When there is in procedures, when ethanol sclerotherapy is done for AV malformation or venous malformation, post-procedure, there can be airway swelling, there can be temporary hypoxemia because it can affect the pulmonary vasculature and cause ventilation perfusion mismatch, but this is for a very short period. There can be hypoglycemia and sudden cardiorespiratory. The causes are not known. During balloon angioplasty and stenting of occlusive cerebrovascular disease, the patients can have cerebral ischemia. So you need to have deliberate hypertension to increase the flow across the collateral circulation. Patients can have concomitant coronary artery disease. When they're doing balloon angioplasty, because of the stimulation of the baroreceptors, there can be bradycardia and hypotension. So anticholinergic like atropine may be required. And again here, because of the chronic hypoperfused area, now when suddenly the circulation is restored, there can be normal perfusion pressure breakthrough. In balloon angioplasty or pharmacological treatment of cerebral vasospasm secondary to aneurysmal subarachnoid hemorrhage, there are concerns of cerebral ischemia, and blood pressure should be maintained little at the highest side to increase the collateral flow. And in these procedures, you keep the patient supine until the femoral sheath is removed, and firm compression should be applied over the femoral artery. Good post-op analgesia is required. Maintain good hydration to prevent contrast nephropathy. Control the post-op contrast can cause post-op nausea, vomiting, so give good emetics. Maintain a modest hypotension to prevent perfusion pressure breakthrough. Continuously observe for continuous neurological observation should be done. If the patient has subarachnoid hemorrhage, then nimodipine may be required every 6 hourly to prevent vasospasm. Aspirin 75 milligram is continued for 3 months, and in the post-procedures period, heparin may be required to prevent thromboembolic complications. And if heparin is continued, then the sheath should not be removed in immediate post-procedure period. This is the picture showing pre and post embolization. And this is the aneurysm, which is before the coiling and after the coiling. You can see the coils in the aneurysm. Now, there are certain, I would like to discuss in short about certain procedures where the anesthetist input is required. So like for sclerotherapy of venous angiomas, craniofacial venous malformations are congenital disorders which can cause cosmetic deformities. They can impinge on the airway and interfere with swallowing. So 95% ethanol opacified with contrast is injected percutaneously under the fluoroscopic guidance. This results in chemical burn to the lesion and shrinking of the lesion. They are short procedures but painful, so general anesthesia is generally required. If the airway is involved, then consider fiber optic or elective tracheostomy. In the post-procedure, there can be airway swelling, so the airway must be carefully assessed before extubation is done. As I told you, during ethanol injection, there can be changes in the pulmonary vasculature and ventilation perfusion mismatch. So there can be a drop in 2 to 3% drop in oxygen saturation, which is momentary. Cardiac, there are reports of cardiac arrest and hypoglycemia following ethanol injection. The cause is not known, and there can be post-op agitation in children. Now, certain if there's intractable epistaxis, which is not controlled by anterior packing, these patients can be taken in the interventional suite, and the branches of the external carotid arteries visualized by angiography, and you can use polyvinyl alcohol or oxidized cotton flagellates for embolization. But one must keep in mind these may be elderly patients with associated hypertension, atherosclerosis, coagulopathy, or vascular degeneration. They may be hypovolemic, so you restore the blood volume before induction. The stomach can contain solid blood. So if you're doing in sedation, be careful that you don't give minimal sedation should be given, other there is a risk of aspiration. And in general anesthesia, rapid sequence induction should be done. Now, there is increase in incidence of liver disease in the past decade due to liver cirrhosis, non-alcoholic cirrhosis because of fatty liver, or hepatitis B and C. And portal liver cirrhosis can cause portal hypertension. And the transjugular intrahepatic portasystemic shunt is the minimally invasive option to reduce the portal venous pressure, where you create a shunt between the hepatic vein and the portal vein. Now, there are certain preoperative considerations when you're anesthetizing these patients. There may be risk of aspiration because of GI bleed, increased intragastric pressure due to ascites, decreased level of consciousness due to hepatic encephalopathy. The FRC may be reduced due to ascites, pleural effusion, intrapulmonary shunts, and pneumonia. The cardiovascular system can be affected due to alcoholic cardiomyopathy. They may be hypovolemic, hypotensive due to acute hemorrhage from the esophageal varices. Liver cirrhosis can lead to coagulopathy and thrombocytopenia. So very careful when you're doing intubation. Patients.
Sorry to interrupt, ma'am.
Just 2 minutes, okay? Finished.
Okay.
Yeah, and if the patient has pre-existing hepatoencephalopathy, which is a relative contraindication for TIPS. Procedure causes minimal stimulation but can last for prolonged period of time, so preferably done under general anesthesia because lying supine for prolonged period can be uncomfortable. Cardiac arrhythmias may be expected during TIPS implantation. Respiratory motion, you need to have apnea during passage into the portal vein, and there can be complications of GI hemorrhage requiring an emergency airway management. Now, 2007, just 2 minutes, okay? In 2007, the RCOG, the RCR, and the British Society of Interventional Radiology released a joint practice statement that all obstetric units are consider intervention radiology and as an important tool in the prevention and management of PPH. So if it's an elective uterine artery embolization, uterus is shielded with a lead apron during the procedure. Sheaths are introduced under local anesthesia to reduce the induction to delivery time. For emergency cases, all medical measures, if the medical measures...
we have Zoom only till 8 p.m. So
Pardon?
We have the Zoom link active only till 8 p.m.
Okay. So just, okay. Yeah. And the other procedures which can be done are endovascular treatment of aortic aneurysm, percutaneous transluminal angioplasty, and of course, inferior vena cava filters, which are done under local anesthesia. So to summarize, the intervention radiologic suite is not a familiar environment, needs thorough understanding of the pathology and potential complications. There can be risk of anticoagulation, radiation, and contrast reaction. It's very difficult to access the airway in an emergency situation in the radiology suite and ensure safe administration of sedation and analgesia. Thank you.
Thank you very much, ma'am, for such an informative talk. It is very difficult to cover everything in 20 minutes.
Huge
But
topic.
yeah, it's a very huge topic. Thank you for a very enlightening talk, ma'am. So I thank all the speakers to enlighten us today on the NORA topics. Now, we all now move ahead after having plethora of knowledge on non-operating room anesthesia. Why this topic was selected actually? Because it's a very peculiar setup with where everything is limited, right from trained staff to familiarity of the equipment and getting help, and except the fact that we would be held responsible if anything goes wrong. But the medical care is evolving day by day, and the procedures happening outside the operating room are increasing day by day, extending from the GI endoscopy suite to CT MRI to cath lab, and extending to the space in near future, because so many space missions, and they are they are undergoing so many training in the space and everything. We have to be evolving, and we have to gear up. So, to get thorough knowledge and practical tips of what to do and what not to do in while anesthetizing a patient outside the OT, we have a panel discussion. And for panel discussion, I would like to invite esteemed panelists, Dr. Vikas Nair, sir, who is a consultant anesthesiologist.
I'm here.
Good evening, sir. Welcome.
Good evening, everyone.
Yeah. He is a consultant anesthesiologist at Zen Hospital, Chembur. He has special interest in medico-legal issues, and he was a past president of IMA NEBS 2008 to 2009. He is MD Anesthesia and LLB as well. So we welcome you, sir.
Thank you.
Moving to the next speaker, next panelist. We have Dr. Kinjal Modi, sir, who is a consultant respiratory physician and medico-legal consultant again. He is practicing for around 17 years at PD Hinduja Hospital, Khar, and Western Suburbs Hospital. He is pursuing, he is MBBS, MD, DNB in respiratory medicine. He did his interventional pulmonology from Malaysia. He did LLB from Mumbai University, and a few diplomas in law and hospital management. And now he is pursuing LLM. So he has many national and international publications to his credit, and is a MMC accredited speaker and accredited observer also. Apart from that, he is a marathon runner, singer, poet, YouTuber with more than 75 videos on his channel. I'm sure, sir, you're going to get more subscriptions and likes from today.
Thank you, Renu ma'am. Thank you for the invitation.
Yeah. So moving on to the next panelist. We have a senior consultant radiologist practicing in Malad, Kandivali, Borivali with Nirman High Tech since last 20 years. We welcome you, Dr. Meenal Seth, madam. She is helping almost all the leading physicians, surgeons, and fellow doctors in getting the right diagnosis.
Renu, share the CV slide.
Sir, it's not shared?
No.
Okay. One sec. Sorry.
Renu, it's okay. You can continue.
Yeah. I think it's not moving ahead.
Can you hear me?
Yes, ma'am.
It's okay. Continue. Don't waste time.
Exactly.
Yeah.
Because we have limited time.
Yeah. Oh, I lost my slide. 1 minute.
That's okay.
Yeah. We welcome you, ma'am.
Thank you.
Yeah. Yeah. So he has done, he's past assistant consultant at Harkisandas, Charni Road, and she's specialized in cardiothoracic and neuroradiology. We welcome you, ma'am. The next panelist we have Dr. Nishant Aditya, who is a consultant interventionist and intervention neuroradiologist in HN Reliance. He's performed more than 100 intracranial aneurysm coilings, arterial recanalization for ischemic stroke, including mechanical thrombolysis using Penumbra, Solitaire, and Revive. And embolization of brain AV malformations, dural AV fistula, spinal cord vascular malformations, and many more. He has done spine and pediatric neurointerventions, vein of Galen aneurysmal malformations, spiral AV malformations, and spinal AV malformations. We welcome you, sir.
Hello. Hi.
The next panelist, we have a young dynamic Dr. Darshil Shah, who runs an endoscopy center at Mumbai Gastro and Liver Care Clinic in western suburbs of Mumbai. He is various papers and publications under his name, and his forte is diagnostic gastroscopies and colonoscopies, therapeutic gastroscopies and colonoscopies, and therapeutic ERCPs. Welcome, Dr. Darshil, sir. I would also like all the speakers to also be present during the panel discussion. We are going to start the questions. There are a few set of questions which are already there in the chat box. I will read the questions to you to all the panelists. The first question is to Dr. Vikas, sir. Sir, what are the medical legal Vikas, sir?
Yeah, I'm here.
Yeah. Sir, what are the medical legal implications of non-operating room anesthesia? What is the basic minimum monitoring standard? And are there any guidelines regarding post-op observation in CT and MRI? So we'll go one by one. Sir, medical legal implications of NORA.
No, let me start with the mandatory monitoring is the question,
sir.
right?
Yes.
So
sir.
as much as impractical as it may sound or be seen, there is no difference between the standards of monitoring or the grade of monitoring in between a NORA case and a case which is done in a regular operation theater. So unfortunately, whether you may be having a MRI compatible monitor or not, you are supposed to be doing all that, the monitoring. Then you should have the theater or the radiology suite or whatever it is as near to the operation theater as possible. You should be having oxygen with an backup, 2 working suction machines, all your monitor, anesthesia machine, etc. So there is no much of a difference between the requirements in a NORA case as compared to a case in the operation theater. Obviously, it goes without saying there is a presence of a qualified anesthesiologist required everywhere, NORA or in the operation theater.
Okay. All right. I think that answers the query. Sir, then the next query is the medical legal, professional indemnity insurance, does that cover all these areas where there is no ventilator backup or means no ICU backup? So the question is, our professional indemnity, does that cover in case of medical legal?
So as long as all these things are met, all these conditions are met, that is, you have a proper anesthesia machine and all the requirements which I mentioned about oxygen, about suction, etc., etc. Some of the companies covers these policies, while many others don't. So we have to read the fine print before you actually know what your company is offering. So I would like to mention about a case if there is time. This is in a MRI room which has happened many years back, which is also known as the Michael Colombini case, which was about a 6-year-old boy who was taken up for MRI in the MRI suite. And on giving anesthesia, the child started desaturating rapidly. So as we all do, the anesthetist there increased the oxygen inflow through the nasal prongs. But unfortunately, the child continued desaturating. He panicked. He asked his regular MRI technicians to go and find out what is the matter. So both the technicians went out, but they had to go to the oxygen manifold, which was in the ground floor, and this was in the first floor. In the meanwhile, a nurse came there for some other case, and she heard this anesthetist shouting, "Oxygen, oxygen!" And she suddenly pulled in an oxygen cylinder, which was there in that zone 3 station, and gave it to the anesthetist. The anesthetist, in all that panic, pulled it into the MRI suit, and it went in as a projectile missile, and it caused intracranial injury to the child. The child later succumbed after 2 days because of all this. There was a suit against all this, the MRI office, the MRI directors and everybody. And finally, it had to be settled with some compensation. So that is how it goes.
Thank you, sir. Next question is to Dr. Kinjal Modi, sir. Sir, while planning a bronchoscopy, when do you call an anesthetist? When do you decide that you will need an anesthesiologist for your bronchoscopy, or you call for all your bronchoscopies?
Practically, madam, in the initial days of practice where I was being trained, we hardly used to call anesthetists. But then as you learned that I had done my medical legal education also, so then they made me understand that without any procedure, any surgical procedure done without anesthetist, you might land up in problem. So basically, we always call anesthesia either standby or if 99% of cases, general anesthesia, sedation, things are done. So with the standby anesthesia or a sedation given by a interventionist during a ICU procedure, things are quite okay. But it's at least on standby. Even in a setup like Hinduja and all these places, we have to have setup like that. You can just ask for an anesthetist standby. They will just intervene when required. Otherwise, they will be there around. So that makes things very easy. If the patient collapses or there is any medical emergencies during the time of the procedure, we have anesthesia. They are knowing the patient in beforehand and they can intervene immediately. Otherwise, what happens that we are not, anesthesia people are not informed. Then they, I'm not audible properly. Am I audible?
In between, your voice was breaking. Now you are audible.
Audible, yeah. Thanks. So if I'm not, then please let me know. So basically, what happened is you earlier that if you are not informed anesthetist at all in the initial part of your procedure, then they will come, they will search the files, what is a pre-morbid condition for the patient, all those things, time will be wasted. Means precious time is wasted in all those conditions, and then they start acting. So if they are informed beforehand and if they are available, then things are very easy. For patient who have cardiac illnesses, any respiratory, basically, if the patient is comorbid conditions are very strong enough, definitely anesthesia, full anesthesia, or anesthetist, whatever feels like what better anesthesia can be given. Especially when we go for interventional procedures like some kind of biopsies, TBLBs, we have transbronchial needle aspirations, we have laser procedures and various other things during a bronchoscopy. So basically, all those things generally require a proper anesthesia. We have medical thoracoscopy is also available nowadays, and wards and everything are also done by the surgical people in our field. So all these things require a proper anesthesia to be given to the patient. And definitely, we are in need of anesthetists everywhere. And I'm very grateful. I just have to say beforehand, but I am very grateful that Dr. Rajiv Garud is here. I have found him very thorough because I think it was the first anesthetist with whom I worked during my bronchoscopy days when I used to do. And Dr. Praveen Bhatti is also there. He has helped me many times with the bronchoscopy procedures. Also, thankful to Amula Madam, Shilpa Madam, and all of you over here to invite me on this panel discussion. Thank you, ma'am.
Thank you, sir. The next question is for Dr. Praveen. Praveen, are you there?
Yes, madam.
Yes. There is a patient known case of COPD on bronchodilators for suspected tuberculosis for bronchoscopic lavage. The room air saturation is between 90 to 92%. So how do you plan this procedure for anesthesia for bronchoscopy of this patient for lavage?
I think the most important thing is talk to the patient, explain the procedure, talk to the relatives, explain the procedure entirely. This patient usually requires only MAC, that is minimum monitored anesthesia care, where you give minimal sedation. Already the patients are respiratory compromised. So sometimes before the procedure, we can give a good neb, counsel them, give good assurance, and a small dose of midazolam and fentanyl actually suffices if the patients are good cooperative. They are actually given good anesthesia nebulization before the procedure, the routine oral, topical, as well as some nebulization of the lignocaine helps getting done this procedure easily.
Okay. There's one more question for you, Praveen. While taking biopsy, madam has asked that patient started bleeding profusely, and then lots of cold saline was pushed, and patient was shifted to higher center. So before
Biopsy
shifting,
of what? Biopsy where, madam?
lung,
I
and
d-
I think bronchoscopy.
Okay. Yeah.
Yeah. So maybe bronchus, but then lots of cold saline was pushed. Patient was shifted to higher center. So before shifting, what all things should we do? I don't think there is much time once this happens.
Sorry. So
What
this
should we
is.
do before shifting? Like, I think
I think
resuscitation.
best is to secure the airway and you start all the resuscitation. You secure IV lines, blood and blood products. The basic, the ABC protocol for such patients. Airway securing is the basic for such scenarios.
And call for help.
Call for help, explain to the relatives, you basic resuscitation you start, and then you stabilize the patient and then shift to tertiary center.
Yes. Okay. And now, ma'am, Varsha Vora, ma'am. Next question. Thank you,
Hello.
Praveen. Varsha Vora, ma'am,
Yeah.
there's a question for you. There is a compromised pediatric patient who needs CT MRI. Compromised means mentally retarded. So, is there any change in plan for this patient?
Mainly, first of all, can you hear me?
Yes, ma'am.
Yeah. First of all, you have in a PAC, you have to know whether the patient is drooling, patient has what problem, other, and after that, explain them to give if there is any respiratory infection or anything, then you have to first treat that and then only take the patient for MRI. And if there is a severe respiratory, then it may require admission and then do. CT MRI is not an emergency. And compromised patient, if they are ASA 3 and 4, we can shift to higher center, and otherwise we can do under LMA or IGL.
Thank you, ma'am. Next question is for Dr. Meenal, madam. Ma'am, when do you plan that this patient will require anesthesia for CT or MRI?
Okay, so the most common indications for doing MRI under anesthesia is claustrophobic patients. So those are elective patients. So you can actually post them according to the anesthetist requirement or anesthetist presence. The second is again pediatric patients who don't who are not cooperative. For CT, again, the same thing is applicable, claustrophobic. Usually the CT bore is quite, it's not very claustrophobic kind. So most of them, but still there are patients who may require anesthesia. Somebody who's not cooperative at all, where where just holding the patient is not going to suffice, because sometimes the MR and CT procedures or the scans which we are going to do are probably more than 3 minutes or 4 minutes. In that time, so MR is usually a longer procedure, CT is shorter, but still there are procedures or there are scans in for CT which may probably take more than 5 or 10 minutes. In those patients, we would require anesthetist. Then there are patients who are known allergic to something. So they say that we are allergic to these drugs, we are allergic. So they are more prone to having allergy to the IV contrast that we are going to give. So in such patients, we keep anesthetist standby. So they are there around for giving, if there's anything mishap that is going to happen, they're the ones who are going to tackle the reactions. Usually doesn't.
Ma'am, your voice is cracking.
But we for can you hear me? Can you hear me now? Yeah,
Yes,
okay.
madam.
So for the safety of the patient and for the safety of the radiologist, we keep an anesthetist standby. So half of our burden is taken over by the anesthetist. Having said that, we've also called anesthetist for lowering the heart rate when you're doing coronary CT.
Ma'am, we are not able to. Ma'am, you are not audible clearly.
Geographies.
Your voice
Can you
is
hear me
cracking.
now?
Your voice is
Now?
cracking.
Can you
Yes,
hear me now?
better.
Okay, can you hear me now?
Yes.
Okay. So when we want to lower the heart rate of patients, so that time we call the anesthetist to give IV beta blockers. So these are the commonest indications for calling an anesthetist.
Okay, ma'am. Thank you. So, ma'am, there was a question regarding contrast.
Thank you.
Ma'am, do you give steroids to all the patients who
Yeah.
need contrast with a known allergy to other things? Do you recommend? There is a question which asks
No,
for.
we don't.
Okay. Thank you, ma'am. Thank you very much.
Yes.
Yeah.
There's
Uh,
bad signal probably. The network is not good. Can you hear me now?
Yes, ma'am. We could hear your answer. No
Can you
problem.
hear me?
Yes.
Okay. So, yes, whoever tells us that they are allergic to something, we usually push in IV, Avil, and Efcorlin.
Ma'am, there is one more query. Do you train your staff in the MRI and CT for anesthesia procedures? Because generally that's the most
For
difficult
injecting
area.
contrast media.
Ma'am, there is one more question. Yeah, so training of your staff for
Yes, I can hear you.
emergencies, training of the CT MRI staff and help, because
Technician and staff.
yeah,
Yes.
technician and staff.
Yes.
Do you recommend training them for
Yes.
emergency,
Yes.
especially the
Very
airway
important.
catastrophes and CPCR, maybe at least
Yes.
BLS?
Yes.
Okay.
Yes. Yes.
Okay. Yeah.
So we radiologists as well as the anesthetist who's there, we both train them. That's the most important thing that we do because the emergency tray, the ABC thing, everything is done by, it's a combined effort of the radiologist as well as the anesthetist who train them. So it's been 22 years that we've been doing this, and the staff has to be trained for all these procedures or all for rapid action.
Yeah.
Can you hear me? I think
Yes,
the
ma'am.
signal is not very
You were
good.
audible. No problem.
Also, a MRI safety
Yeah.
drill should be done to all the members of the MRI centers, to all the staff of the MRI centers, so that they know what goes in and what cannot go in.
Yes, sir. Absolutely. Moving on to the next topic of GI endoscopy.
Yes,
Dr. Darshil.
absolutely. That's the most important
Yes,
thing.
Dr.
So,
Darshil.
that has to be done.
Dr. Darshil, are you there? Sir? Darshil, sir? Okay. Sir, the question for Rajan Daftari, sir. So there is a question of ERCP in prone position, and whether you recommend total intravenous anesthesia with spontaneous breathing or with endotracheal tube and GA for ERCP, even in lateral position.
So no, there is no recommendation of that where you need to intubate your patients when you're doing an ERCP. Okay, unless your patient is so sick that you want to take all control in your hand, but that rarely ever happens. For a patient who is in prone position also, there is no need to intubate them. In fact, you will find that they very rarely desaturate simply because the tongue never falls, so they never desaturate action.
Achha.
Are you able to hear me?
Yeah,
Your
now we are.
expressions give me the feeling that you're not
You were
hearing.
not audible for a few seconds.
Yeah, so no, intubation is not a must, not necessary at all. You could do the same thing. You could do a prone position also under TIVA, not a problem.
Okay, sir.
The important thing is you need enough people over there to shift or change the position if the need arises. So adequate staffing of your endoscopy suites is very important.
Okay, sir.
I would like to add here that in a survey of close claim survey involving hospitals over a period of 20 years, the number of cases were the maximum in cases involving colonoscopy, while the quantum of compensation was the most in ERCP cases.
Okay. Is this data from India or is it from abroad?
No, this is not from India. This is from abroad.
Correct. So the reason for that is very simple. As I told you in my lecture, that more often than not, the people who are giving sedations are not
Are not
anesthesiologists. They are
anesthetists.
nurse anesthesiologists or sometimes the endoscopists themselves. So I'm not surprised that they find hypoxia as such a common occurrence in their scenarios. Okay. For a trained anesthesiologist, I don't think this should happen. It's not such a rocket science so long as you know what you're doing and
No,
what drugs you're
this doesn't pertain only to anesthesia. This is about the procedure too.
Yeah. That is because colonoscopy remains their number one procedure as far as the numbers are concerned. So
Correct.
if you take that as an important factor, surely you will find that the incidence of getting sued is also proportionately high.
Correct.
But that doesn't make the procedure of colonoscopy dangerous. So I don't think people should get scared if they are called for giving sedation or anesthesia for colonoscopies.
So can we go to the next question? Yes.
Yep.
Sir, for Rajan Daftari, sir, there is a question. There is a frail patient with deranged LFT who is posted for variceal banding. So, how do we go about it? We give GA or
So,
if we intubate?
so yeah. So I would know the
No.
the frailty of the patient is not the reason for intubating the patient. You will obviously adjust your drug dosages accordingly. Now, most of the poorly controlled liver disease
So, your
patients,
voice is gone.
I'm not moving anything. I just have to hope and pray that
We
the
can hear
system.
you now.
Okay. So no. So intubation comes into play only if you are worried that there's going to be bleeding going on or there is going to be bleeding which is happening. If you are confident of your gastroenterologist and his skill sets, there is no reason to preemptively intubate them. Because if your patient is very frail and you were to give complete general anesthesia, I'll be more worried about extubation and then managing this patient than give controlled amount of sedation while giving total intravenous anesthesia.
Yes.
Okay, so that's all right, not a problem.
So, next question for you again. What are the fasting guidelines for GI endoscopies?
Absolutely strict, very strict. Please do not compromise on that because, like I said, if there is one thing that I'm scared about, it's regurgitation and aspiration. Okay, so don't compromise on that. They will tell you all sorts of things that he has just had a cup of tea or he has just had a half a biscuit or one biscuit, and when you put your scope inside, you will find a lot more stuff lying around over there. So please fold your hands and say that it's not worthwhile taking up this patient for a diagnostic procedure. It is best to wait or call him on some other day when he is completely starving. So there are no compromises on that at all. Especially if you are doing pediatric age group patients, please be sure that the child has not been given whole milk because then you need much more
Solid.
larger starvation period. Okay.
Yes.
And the other thing is, after practicing for so many years, this 6 hours guideline of starvation is not sacrosanct in very sick patients. When you get a patient who is very sick, you will find that the starvation period may be even 10 hours and still there is enough food lying in the stomach. Okay. So use your judgment properly. Wherever you think that this is going to create problem, be firm about what you are asking for and ensure that you don't end up with a complication.
Okay. Sir, there is one more question. FB foreign body removal in emergency in a non-fasting patient. For example, if it's a corrosive thing or if it's a means we can't wait for the foreign body for the fasting status to be adequate.
You're referring to a button cell, I presume.
Yes, yes.
Okay. Yeah. So patient is not fasting and there's a button cell inside. This is the ideal case for intubating and going ahead with the procedure. Why? Because the button cell may be lost inside the food that the patient has eaten. So they're going to take some time fishing for that button cell. You might need to change the position of the patient so that the food shifts and hope that at some point in time the button cell is visualized and it can be brought out. So intubation is a must for this patient. Patient safety is absolutely mandatory. Remember, for all practicing anesthesiologists, don't follow anybody else's rules for yourself. If you are more comfortable intubating a patient and doing an ERCP, please do not change your techniques. Okay, because what works for me and what works for my setup might not work for you in the setup that you might be doing. You may be having an endoscopist who takes much longer period of time for doing that same procedure than what people at my end would be. So therefore, there cannot be such strict guidelines about should I put in an endotracheal tube or should I put in an LMA and such things. Okay, just to touch a little bit over here, because there are a lot of people who were using LMA gastro once upon a time, especially in your area. My experience with it was not something very great, simply because my endoscopists were not happy at all with that. The movement of the scopes were very restricted. The depth of sedation needed for these patients was far more than what you would need otherwise. And the end result was that the patient remained drowsy and sleeping in your recovery room for many more hours than what otherwise they normally do. So it's not something very fantastic as it was put forward to. And we need to keep on watching whether some newer innovations come up.
Sir, next question again to you is, if a patient with IHD with ejection fraction of 30% with CKD for colonoscopy, so how do we go about it?
So very simple. The same rules as you would use in an OR. Is a ischemic heart disease patient, number one, ensure that there is no hypotension. Why colonoscopy patients will have hypotension? If they have taken their preparations well and they have purged more than enough, very often they are hypovolemic. Okay, so hypotension is something that you should be worried about. Please ensure that your sedation doses are adequate. Why? Discomfort, if it is going to cause tachycardia. Tachycardia is detrimental to an ischemic heart. So don't try and give less. Less may be harmful here. So use your drugs appropriately. I think the use of propofol in these patients can be done very judiciously. If you are scared about the 30% ejection fraction, you can use etomidate and still give great results. Okay. Hypertension also can happen if there is too much of distension of the bowel wall. Okay, if your endoscopist is taking too long to do a colonoscopy, you soon realize that the colon is stretched, distended. Sometimes there is looping of the scope within the bowel. You understand? So the bowel, the endoscope turns on itself. So instead of going forward, the tip is actually taken a U-turn, and that is what is meant by looping. So what happens in this scenario? There is a severe stretch of the colonic wall and the mesentery, which can cause strong vagal reaction and a sudden drop in heart rate. So be very vigilant. If suddenly your colonoscopy patient starts getting pain, that is not an indication for you to give more drugs. That's an indication for you to tell your endoscopist that I think you're looping, you need to straighten out your scope and then progress. And more often than not, that does the job.
Okay, okay. Thank you very much, sir. So there are a few more questions. We'll come back to you in some time. Yeah, we move to the interventional radiology part. Uh, Anaita ma'am and Nishant sir. So there is a problem with CT, MRI, with the interventional tables. They might not have a head low or head high for regional anesthesia, for procedures which were planned under regional anesthesia. So ma'am, Anaita ma'am.
Hello. Yes.
Yes, ma'am. So, ma'am, interventional radiology tables, they don't have head low or head high. If we give regional anesthesia, then
No,
that's
one
the
thing
query.
is you can induce the patient in the normal OR and then shift the patient to the interventional suite. Or you can actually, I don't have personal experience of giving regional. What I have usually given is either sedation or general anesthesia in the interventional suite. Or you can use isobaric bupivacaine, which causes less incidence of hypotension.
Okay. Okay, ma'am. And ma'am, one thing that suppose the procedure has been started by the interventional radiologist, Dr. Nishant, sir, for example, do you call for all the cases, do you call anesthesiologist or you do some under local anesthesia?
So, as the first medical legal expert, am I audible?
Yes, sir. Absolutely.
Thank you for invitation. As first medical legal expert in the very first introduction, he said it is non-operative or operative, anesthesia remains same. That is very true for all neurointervention procedures. Even for diagnostic DSA, I keep anesthetist standby. All intracranial procedure will be done under GA.
Okay, sir.
So there is nothing that there is no anesthetist in the room.
Okay.
And for neurointervention is nothing like NORA. It is like now SORA, super operative room anesthesia, because it's really super work nowadays for stroke. As a neurointerventionist, we are doing all across the world. So it's a very challenging field now, becoming as a neurointerventionist, dedicated neuroanesthetist.
Okay. Thank you, sir. Ma'am, for example, the endovascular laser ablation of varicose veins, all these procedures few people do under local anesthesia, and then when they land up in a problem or the patient is uncomfortable, then they call for anesthesiologist. So how do you go about it? Like, would you anesthetize or would you ask them to reschedule the surgery? Or
depending on the pre-op condition and whether the patient is starving or not, and then only we will go for the anesthetizing the patient. But if the patient is not optimally prepared, we would not need to go ahead with the procedure.
Yes.
We'd like them to schedule some other days.
Yes.
In our center and even in KEMO, they usually have an anesthetist for all the procedures.
Okay. Okay. Thank you, ma'am. Next question is for Rajan Daftari, sir. Sir, someone had asked about spinal for colonoscopy and lignocaine lozenges while doing upper GI endoscopy. You had mentioned about lignocaine spray, but lozenges was a query.
Yeah, so the issue is that if you're giving adequate sedation, you don't need that lignocaine to blunt the response of your endoscope. In any case, the endoscopist is applying lignocaine jelly on the scope while he is introducing it, and so that can take care of it. Okay, but say for example, you have a patient who is having COPD, a highly irritable upper respiratory tract, a smoker, yeah. So these are patients who could possibly have hyperreactive upper airway. These are patients where you could use your lignocaine in whatever form you can. I prefer to give them, when I want to use lignocaine, I would rather use 4% lignocaine nebulization. Okay, don't do a 2% nebulization. It's not so effective. 4%, 4 ml of 4% lignocaine nebulization 10 minutes prior to the procedure, and you will find that these patients do far better than otherwise. Okay, my problem with 10% lignocaine is like what I told you, that it is very difficult to comfort a patient who says that he is not able to breathe. Oh, it's very difficult to convince the relatives that no, he is breathing well. Yeah, these are alarm symptoms and you just can't help it. Also, the period of starvation is significantly increased in these patients. Even if they want to have a sip of water, it is difficult to allow them to have it. Therefore, I'm not so much for it. Regarding spinal for colonoscopy, that's an absolute overkill, because I can't understand why this decision is being taken. There are so many options that you can have otherwise for doing a colonoscopy that I would surely not recommend that as an option to be done. Yeah, that would immediately convert that patient into a indoor patient rather than an outdoor patient. That itself should be the first objection.
Okay. Yes, sir. Thank you, sir. The next question is for Vikas Nair, sir. Sir, how much time do you recommend that a patient, after undergoing CT or MRI under anesthesia, for how many hours he should be observed, and what are the things we should advise? When can we leave the CT MRI suite after the procedure is done? And
Exactly like you do for a ASA 1 or 2 patient, where you do such patients under TIVA. So till the patient comes back to his senses and is generally able to take care of himself, you have to monitor the patient, or you have to take care of the patient till such time, because the law always feels that it is you who have made the patient in such a state where he or she cannot take care of himself or herself because of your IV anesthesia drugs. So the response, you are now a trustee of the patient. So you have to wait till the patient can take care of himself or herself. So till such time, the patient may be groggy, but generally as long as he can take care of his airway reflexes, breathes well, you have to be there till that time.
And in pediatric patients especially, how much time should we tell them to be fasting after the procedure, because they are going to go home? So do you recommend a prolonged
No,
fasting?
I generally allow oral intake once the child starts crying and responding.
Okay. Okay, sir. All right. Uh, There was a question that should CT and MRI suits be attached to they should have affiliation with a nursing home or with a ICU backup, so that if any patient anytime requires shifting, that should be readily available.
That will be ideal, though it is not practical in some of the small places where CT and MRI. But it will definitely go a long way if there are any legal hassles against the particular MRI or CT center.
Okay. All right. Sir, next question. Thank you, sir. Next question for Dr. Kinjal Modi, sir. Sir, do you ask the patients to stop antithrombotic agents like clopidogrel or aspirin when you post the patient for diagnostic bronchoscopy, or is clopidogrel safe?
See, madam, clopidogrel basically depends on what we are going to do. If it's only diagnostic scopy, doing only a BAL, with due risk, we can go ahead depending on the cardiac status of the patient. Because if it is we don't take risk benefit ratio. If stopping anticoagulant is going to be more harm from cardiac perspective, better to let it be continuing. Ecospirin definitely is no issues. We have done multiple scopies with ecospirin on. Clopidogrel generally we try to avoid at least stop for 5 days. Because while doing a scopy, if the patient coughs, there is some kind of abrasion which is going to occur in the mucosa and bleeding might occur. Especially if you're going to plan a invasive procedure like biopsy or something, definitely we have to stop any anticoagulants. Nowadays, we are just to add on to the rivaroxaban. The Xarelto is one of the medication which is already being on. It is very good that 1 to 3 days is sufficient for stopping it before the.
You are not audible, sir. Sir,
I was audible or?
no, your voice was gone for a few
Lost.
seconds. Yeah. Sir,
Okay.
then
Was my answer audible or repeat again?
you are audible. Now you are audible.
You are audible up to rivaroxaban.
We will move on to the next question till that time. Is video PAC allowed for all these procedures? Dr. Vikas Nair, sir, can you throw some light on video consultation?
So the best thing is to have a physically written consent on paper. A video consent would be an added advantage. The only thing is that we should, before doing anything under video or on telephone, is that you should first inform them that we are doing a video taping or a audio taping. So that is as
consultation as a pre-anesthesia checkup, what we do, PAC.
I thought you were talking of consent. Sorry.
No, sir, not consent.
Okay. So come again, please.
Sir, is the video PAC valid in the court of law?
So as
or audio on the telephonic consultation?
But just before the procedure, you would have to examine the patient, right?
Yes.
So that itself forms a physical sort of PAC. You examine the patient, that can form a questionnaire. Your video or a audio consultation can form a preliminary questionnaire, and then based on that, you do your physical examination. Mention whatever you have done on your PAC paper. That should be good enough.
Okay. Yeah. Thank you, sir. Kinjal Modi, sir, you can come back on rivaroxaban if your connection is secure now. If you are aware.
Yeah. Thank you, ma'am.
Yes, sir.
Many patients are on rivaroxaban also. So basically, that is one of the wonderful drugs. But we can stop for about 1 day to 3 days, depending on the procedure we have to do. So generally 3 days is sufficient for that. So clopidogrel 5 days and rivaroxaban 3 days. That is okay. Ecosprin we can continue because that is not a big harm in doing endoscopies for all these patients. Thank you.
Mentioned about LMA gastro and the fasting guidelines. These are the questions which have been added now. So, one more question for Dr. Praveen. Praveen, are you there? Dr. Praveen? I think he's not there. All right. Varsha Vora ma'am, do you use dexmedetomidine and ketamine combination for MRI? I mean, do you recommend using?
Yes, now I've started using. Previously, I was not using, but it is a good combination. I've used for a few patients recently.
Okay, ma'am. So, is it safe, like ketamine and?
But ketamine in very low dose.
Okay.
And even dexmedetomidine 1 microgram per kg body weight. And give always dilution. That is most important.
Okay. All right. Anaita ma'am, are there any thank you, Varsha ma'am. Anaita ma'am, are there any technical difficulties in resuscitating the patient in a cath lab because the C-arm is I mean it's all over the patient's head.
Yeah, resuscitation is definitely difficult, but you can take the table down and then you can do resuscitation of these patients. Securing the airway is more difficult.
Yeah, securing the airway because it is away from the.
Yeah. So the image intensifier of the fluoroscopy is on the head end of the patient.
Right.
You can just shift the table down and then do the resuscitation.
Okay. And ma'am, do you think a high-risk consent, separate high-risk consent should be taken for all the procedures who are undergoing coronary angioplasties or patients who are compromised and in addition to the normal anesthesia consent, which we take in all patients, even though we are doing monitored anesthesia care, do we need to take a separate high-risk consent?
No, the consent forms mentions everything. So in that everything is explained to the patient.
Okay,
and
ma'am.
even if it's a monitored anesthesia care, you have to take the same consent as you take for any patient undergoing.
Yes. Okay, ma'am. Thank you, ma'am. Rajan Daptari sir, there is a question. Once during ERCP, ma'am had to intubate due to over distension of abdomen. So, yeah.
No, all they had to do was bring their scope back into the stomach and deflate the stomach, and that should have done the trick. Okay. But yes, I mean, again, very difficult to imagine what was going on and what this case description denotes. If the distension is so much that it is causing compromise to the oximeter levels, and surely ask them to take the scope out, put in your tube, and then continue with the procedure. There is no contraindication itself, because when the scope went in, it would have ensured that the stomach is empty. So you're not worried about regurgitation and aspiration. It is now that the patient is so distended that the patient is probably getting respiratory embarrassment, and that excessive hyperventilation is causing too much of movements for them to do effective work at the papilla. Okay, this is when they start complaining. That is when probably you would intubate, paralyze, and then reduce the respiratory rate and have a possible chance of successfully doing an ERCP. But again, that's what I say, that if you are working in a situation where the endoscopist is going to take a lot of time, then these problems can crop up. You have to find the solutions to your required situation. If you think that they're always going to take time, electively intubate the patient and go ahead with the procedures.
Okay.
Yeah, they will be probably happier with a quieter, meaning less moving patient because of the respiratory movements than otherwise.
Yes, sir. Sir, the question about the frail patient, further it has been elaborated in the chat box that the patient's age is 75 years, hemoglobin is 8 grams, bilirubin is high around 3 milligrams per deciliter, and platelet count is 50,000. And the surgeon wants to do under with the same investigation. So, what sedation will be better, and then should we proceed, and what all things we should prepare?
So I see this situation every day because we are probably one of the very high volume liver setup. Okay. So we do get patients who are very old, who are very frail, and who have portal hypertension related issues. So they keep on coming up for check scopies, or they keep on coming up because there is melena where we need to check in. So there is no reason to get worried about that. Okay. All these patients have a platelet count of hanging around 50,000. That's the nature of liver disease patients. So don't expect them to have counts which are 1 lakh, 1.5 lakh. In fact, I have been shown in writing by the hepatologist that platelet counts should not be the reason not to go ahead with an interventional procedure to stop a GI bleed. So, you theoretically speaking, even if you have a 20,000 platelet count, that doesn't mean that I'm going to refuse, but surely they should understand that that demands a immediate platelet transfusion to bring a stop to the bleeding that is happening. So, arrange for a single donor platelet, let the single donor platelet go, and simultaneously take up the patient and go ahead with the procedure. Okay, so frailty is a part of liver disease. Yeah, they are hypoproteinemic, albumin levels are low, so you cannot expect them to be really good. All right, so it's that is not to be worried at all, not to be, yeah. But surely in these patients, no, I would never touch fentanyl. This idea about using midazolam and fentanyl and then propofol, I don't
Right.
see any reason. I don't see a reason to use a narcotic which could probably cause sudden respiratory depression or prolonged respiratory depression or something like that. That is where you be smart and use a drug like ketamine in the appropriate dose. Midazolam is completely out in liver disease patients. Don't even dream of touching them. Otherwise, you will find that your patients are so drowsy at the end of it that they will not even get up. And if they are borderline into a situation where they could be having hepatic encephalopathy, then you will make matters very, very worse. So, as a rule, don't touch midazolam for your CLD patients at all. Okay. Xylocard is a drug which I use in plenty, and you people can try. It's a fantastic drug. Why? Because A, it obtends the cough reflex, so the patients don't start coughing when the scope is going across the cricopharynx. Two, it reduces the incidence of laryngospasm to a lot of extent. If you land up with laryngospasm and you give a bolus of IV Xylocard, you will find that very often that responds to that. Three, we all know today it's not just a local anesthetic, but it's a fabulous analgesic. People are using it in pain clinics to give as a drug for acute pain, also in drip form. So that's an additional pain relief medication in my drug or in my drugs that I'm giving intravenously. So I will ignocaine along with ketamine, along with appropriate doses of propofol, and you can manage it well. You should not have much problems.
Okay, sir. Sir, next question is about pigtail insertion. So the bilirubin levels are usually very high, and if we are called for again the same on the same lines, what should we give? Should we ask them to start under local anesthesia and then give minimum?
See, I tell you like this, that today audit tells you that 40% of the cases that are happening, if you consider all the procedures, OR and non-OR, 40% of them are being contributed by non-OR. That's a large number. Okay. The OR is saturated by the anesthesiologist. So the smart anesthesiologists are those who will try and concentrate on non-OR, which anyway people are scared to go. Okay. Become super efficient at those things. Don't show that you are scared. What are you worried about? You're worried about very high bilirubin. So you're worried about bilirubin causing bradycardia because of its direct effect on the SA node. You have a lot of drugs to take care of that. So that is not the problem. The problem is if these patients are in cholangitis because of obstruction, then you have to be smart enough to know that they could be having a very labile cardiovascular system and use your drugs appropriately so that so that there doesn't happen a sudden fall, or be ready with drugs like phenylephrine or ephedrine to take care of these drops intraoperatively while the procedure is going on.
Can we use
So
phenylephrine? Because
yeah, you can.
bradycardia.
Yeah, you know that phenylephrine by itself causes it, then you use ephedrine. If you're worried about if there is an associated bradycardia with hypotension, then I'll use
Ephedrine.
ephedrine. Yeah. So you got drugs handy. These are not difficult drugs to manage. All of us have got used to it in the OR, so not a problem at all. So you must help them. You must give them something. That's a place where you could use your combination of IV lignocaine and ketamine, okay, so that the patient is less responsive to pain. You should create a scenario where they become so dependent on you that they cannot ever think of doing a procedure without you. All right?
Yeah.
And this is not a dream situation. This is a distinct possibility. People become so dependent on you that they actually get edgy when you're not around. That's what all of you should be aiming for. So don't say that, no, I'm just standing by. Standing by doing nothing is a worst scenario as far as I'm concerned. That means you're just watching and you're going to be taking care of a sudden crash or a sudden major complication, which anyway was never created by you. So rather than that, become proactive. Don't keep on worrying about whether medico-legally I am going to be affected or not. The fact that you're in the room means it will apply to you, irrespective of whether you've done anything or not. Then why not make it safer? Very often you will find that there will be no nasal oxygen given to this patient because they're putting in a pigtail catheter. So at least try and improve that situation. Put in a nasal oxygen cannula. Use your hands. Okay, what do I mean by use your hands? Your hand on the patient's hand or on the patient's forehead is probably one of the greatest calming things that you can ever have in your life. Try this out for those who are not using it. Okay, what you did for your kids when they were small, when they were agitated, when they were upset, do the same things to your patient. Talk to them well, reassure them, tell them you are there to take care of them. You will suddenly find that that high heart rate also starts settling down just by the talk. That hand on the forehead is something which they remember when they come back again. Okay, so it is so vital. Don't get addicted to drugs. Drugs have their limitations, drugs will have their own complications. Don't minimize what you can do by your talk and by your touch. Use this more than adequately. Let them know that you are there. Don't remain in the background. You've been called for a CT MRI. I see people getting into the area where they are all sitting over there, hardly having had a talk with the patient or hardly having reassured the patient. Anyway, that patient is claustrophobic. He's petrified. Now, suddenly trying to sedate and quieten that patient needs a lot more drugs, then reassurance, telling them that nothing can go wrong, teaching him a few techniques of breathing. If you have done yoga, you know what to do, what to tell. So just do some of those things, add a little bit of medicines, and life becomes very simple. Not so difficult.
Thank you very much, sir. We have one question for Anita ma'am. Are there any special precautions or preparations for procedures like balloon dilatation, thrombus aspiration?
Which thrombus aspiration means embolectomy and all.
Embolectomy, yes.
Yeah, the main precautions you say that they should not, embolize distally. So when they do balloon dilatation and all, they use filters so that the atherosclerotic plaques and all should not embolize into the distal circulation. So those filters are used, especially in carotid stenting and carotid angioplasty. Proximal and distal filters are used.
Okay, ma'am. All right. So any more questions or any more salient features or points you would like to highlight
I see a question by Amola over here asking me the experience with ketamine and dexmedetomidine. So I presume she's referring to this, which is available in a combination form. So I have not used anything like that in a combination form, but separately, yes. But like I said, in a little a procedure which is going to take a lot of time. Okay. So classically, I would be using it in an endoscopy or a very, very prolonged procedure where you're anticipating time. Yes. So nothing, I mean, but I don't see anything wrong in it. It should be working well for those who have got used to it. I think enough questions have been raised and have been answered.
Thank you.
Before
Most of
people
our
run
queries.
away, get tired.
There is a short video which Alpesh would want to play. It is about the Yuva Mahakon. Alpesh. Okay. I would like to thank all the panelists and the audience and speakers for wonderful interactive session today. I would like to invite Dr. Kalpesh Gaitonde for giving vote of thanks.
At the outset, I would like to thank all on behalf of ISA Borivali, all the speakers for the day, especially the eminent teachers like Dr. Anita Shetty, Dr. Rajan Daftari, Dr. Vikas Nair, and our non-anesthesia fraternity for taking out time and dedicating their time for this webinar, excellent webinar. And of course, last but not the least, our very own ISA Boroli members, senior most ones, Dr. Varsha Vora, who enthusiastically attends all the conferences, but today we have given her an opportunity to present, and she did an excellent job. And of course, ISA Boroli, keeping up to its promise of giving UAs the opportunity, we gave another UA speaker, Dr. Praveen Bhati, and of course, Dr. Renu Ranka, who excellently managed the entire show. So I sincerely thank everyone, all the participants, and all the faculty members for attending this webinar on behalf of ISA Boroli Committee. Thank you very much.
Thank you all.
Dr. Kalpesh, we also need to thank Jenica and the SAMS.
Yes, of course. Thanks to the SAMS webinar platform. As usual, they give us uninterrupted services and very good technical support as well. Thank you, Jenica.
Yeah.
Thank you, ISA,
Alpesh,
and
एक
thank you,
comment
Alpesh.
करना था actually.
Yes, Dr. Kinjal,
Hello.
sir, you can
Yeah.
speak.
Yeah, just last comment basically. When I got the invitation from Rajesh sir, then the invitation came with NORA. So I was worried that NORA पढ़ते हैं anesthesia में कहाँ से आ गई. So I mean, really, it was good for me also to understand there's something called as NORA, which actually is a term. Then basically I also read about it something that ये अच्छा ऐसा भी होता है.
NORA is a
We are
trap.
using
Today, Dr. Daftari clarified that 40% of all the cases are NORA.
Yeah, but
And
practically
it is
using
going
it for
to
so many years,
extend
but
to space now.
realize
So
कैसा
we
भी
are
होता
not
है.
limited to Earth. We are going to be required in the space as well.
Yeah,
So
definitely. Thank you.
it will remind you that NORA is related to anesthetist. So please, every time for a NORA case, please remember
याद आएगा.
anesthetist.
Dr.
Yeah.
Kinjal, we already have a very eminent senior anesthetist who has been to Antarctica for almost a year. Dr.
Yeah,
Madhubala
I
Kinjal.
know. Kinchal को मैडम से मिल चुका हूँ. We are there in the IMA committee also. So basically, I met her personally. I have heard a lecture also. Amazing experience and amazing photos.
Soon we will be in the space.
Definitely, sir. Definitely. Next we have the space pictures and space video. You see that, right? Thank you, sir.
Dr. Rajan, Dr. Anita, thank you for your very practical tips. Excellent presentation by everybody. Your valuable tips will really help in these NORA cases.
So I have a suggestion here, and this is based on what I heard during this webinar. I think we should start calling it SORA rather than NORA. That sounds more interesting. Yeah.
Nishant sir had introduced that
Yeah.
term to us.
NORA sounds like as if it is a
negative connotation. Yeah,
third
it's a negative
world
outside.
connotation. Yeah,
correct.
actually,
Because you are doing a limited space super work, so it's called SORA.
Absolutely,
Super operative.
absolutely. It is a super operative thing. It's far more easy to do a high risk laparoscopic cholecystectomy and OR than do a high risk variceal ligation in an endoscopy suite. And we have known in the times where your endoscopy suites is so poorly equipped, it is as good as any OR is. So why run it down?
Now we are getting a biplane system in majority of hospital for neurointervention. So there is a almost not good, is even better than the regular operative setup.
I fully agree with you.
Correct.
Fully agree with you. So thank you, ISA Borivali. I think that was time well spent on a Thursday evening.
Thank you all. See you
Thank
all.
you all.
Again.
Thank you all. Yes.
Thank you, everybody. Thanks a lot.
Thank you, ISA Borivali.
Thank you, everyone, and thank you, ISA Borivali, for this opportunity to ask so many questions to all the experts and get answers to almost all the queries. Thank you for giving me this opportunity to moderate the session. Thank you.
Renu, excellent work.
Thank you,
Excellent
madam.
work.
Thank you so much, ma'am. Thank you for the opportunity. And
Sutradhar the, madam. You can say that way.
yes, sir.
I thank Alpesh also helping me.
Kinjal sir, your voice is not